to inclusion and for helping create a future where every person can participate fully and thrive. The Rotary Club of World Disability Advocacy provides this summit as a platform to learning, dialogue, and the exchange of diverse perspectives. The views, comments, and opinion expressed by speakers, panelists, or participants are their own and do not necessarily reflect the official policies, positions, or endorsement of Rotary International, the Rotary Club of World Disability Advocacy, or its leadership. Rotary assumes no responsibility for the accuracy, completeness, or implication of any statements made during the event. Now, I invite you to see a video about the event. Enjoy the summit. Thank you.
Thank you, Dr. Martha, for those inspiring and opening reflections and very detailed information about our club and what we are doing and what we still continue to do. So we now invite everybody to enjoy the video, which is just a short tour of the summit, the journey that has brought us together today. Thank you.
The Rotary Club of World Disability Advocacy welcomes you to the Disability Health Summit 2026. Hello, I'm Ken Masson, the club co-president. For these 2 days, leaders, clinicians, advocates, and people with disability come together for powerful dialogue and meaningful action. We are honored to start the summit with renowned British sociologist and global disability rights leader, Sir Thomas William Shakespeare. His keynote presentation, Advocating Globally for Patient-Centered Care for People with Disabilities, will help us all better understand how we can advocate for the rights of people with disabilities in all aspects of healthcare system. The next session, Healthcare Accessibility for Policy to Practice, brings together global professionals to examine how the medical industry is evolving to become truly accessible for people with disabilities. Redesigning healthcare, centering neurodiverse voices in every decision. This session reveals how neurodiverse perspectives strengthen trust, improve outcomes, and reshape the design of care itself for people with disabilities. The rise of alternative medicine explores non-traditional approaches that honor individuals' needs, support pain management, and empower people to live full, self-directed lives. And the final session on day 1 is technology, expanding access, independence, and choice. This session highlights innovation, reshaping, and improving medical care for millions of people worldwide. Day 2 opens with a powerful session, Aging-Related Disabilities. Led by a medical doctor from Spain, this provides a deep exploration of aging, autonomy, and the dignity every person deserves. Next, we move into a transformative conversation on rehabilitation, the next line of healing, physical and occupational therapy at the heart of patient-centered care. This session shows how rehabilitation is not supplemental, it's essential. It will provide case studies showing how therapists and people with disabilities will work together in a team toward independence and strength. The mid-morning panel on day 2 is championing patient-centered care. This session honors the caregivers and the advocates who fight every day to navigate systems and shape better outcomes for people with disabilities. A later session in day 2 widens the global lens with a renowned doctor from Brussels who will present a session on health as a key enabler of inclusion. This session is connecting prevention, maternal health, nutrition, and long-term support to long life inclusion. The final session on day 2 is a former doctor from WHO who will lead a discussion on from disease elimination to long-term dignity. This session is going to be examining global efforts to control diseases such as elephantitis and the lived realities of those who are already affected.
All right, thank you so much for the video, and we now officially begin this session. And so we are going to have our keynote session. And as we begin this session, let us just remember that patient-centered care is about seeing the whole person, their dignity, their choices, aspirations, and lived experiences, not simply their medical condition. And so this movement towards inclusive healthcare requires courageous voices, visionary leadership, and a commitment to ensure that people with disabilities are not merely recipients of care, but active partners in shaping the systems that serve them. So today we have the privilege of learning from one of the world's foremost thinkers and advocates in this field. It is now my distinct honor to introduce our keynote speaker, Professor Sir Thomas William Shakespeare, CBE FBA, one of the world's foremost scholars, bioethicists, and champions of disability rights from the United Kingdom. Professor Shakespeare serves as the Professor of Disability Research at the London School of Hygiene and Tropical Medicine, and he's internationally renowned for his groundbreaking work in disability inclusion, rehabilitation, and health equity. As a former technical officer at the World Health Organization, he co-authored the landmark World Report on Disability, a publication that continues to shape policies and healthcare systems across the world. Drawing from both academic excellence and his own lived experience as a person with achondroplasia and a wheelchair user, Sir Thomas has dedicated his life to advancing dignity, accessibility, and equal opportunities for persons with disability. He's an acclaimed author, broadcaster, public intellectual, and a fellow of the British Academy, honored with a CBE for his outstanding contributions to disability research. So today we are very, very privileged to learn from a visionary whose work continues to inspire a more inclusive and equitable world. His keynote address today is Advocating Globally for Patient-Centered Care for Persons with Disability. Challenges us to rethink healthcare systems so that they truly honor the individual, their choices, and their humanity. Ladies and gentlemen, please join me in warmly welcoming Sir Thomas Shakespeare. Over to you, Sir Thomas.
Thank you very much indeed. Let me just share my slides and then I will be able to, here we go. Yes, sorry. Oh no. Come on. I don't want you to see Ebola outbreak stuff. That's not relevant. I want you to see the PowerPoint, which are prepared. Here we go. Can you see this? I hope you can see this. There we go. So I need to put it on to slideshow. And now you should see it. Thank you. I hope you can see that. So you have been very kind, and I am hugely excited to be talking to so many people. And it's really a lifetime work for me. And I show you this slide about me, really to tell you that it was in 1989 that I started doing this work, a long time ago, while I was doing my PhD.
Tom, can you hold on one second? We can't see your slides. No, we can't.
Right. How do I share? I thought I was sharing.
Let's see. You should have rights to do that.
Open system settings, it says. There we go. Does that work better? Oh, goodness me. It says I gotta quit. It's not sharing. Well, I can talk to it. It might be easier because my slides are only words. So if I use my slides for me, you will get the impression of them, and then I can send you my PowerPoint later, and you can distribute it to anybody who wants to see it. Is that okay? Because I don't want to waste your time. All right. So I want to talk. First of all, I want to say something about me. So you can see me, and you can see that I was born with a disability. And what was interesting was that I also had a father who had the same disability. He was a doctor, a medical doctor, a general practitioner in the UK, and my mother was a nurse. And age-old story, they met in a medical school, and they met at St George's. So when I came to Cambridge and I did my PhD about disability and sociological perspective, I was called upon to teach doctors about disability. And my father, who had himself studied medicine at Cambridge, was very excited on my behalf. I was very excited. And so I talked very much the same talk that I'm going to give now, perhaps with less data, but very much same perspective. Then I worked a lot with geneticists because you've been told I was a bioethicist. Well, I spent a lot of time talking about genetic screening. And a professor of clinical genetics at Newcastle called John Byrne said, well, I think you should come meet some of my people and some of the patients we work with. So I did. And we together founded the Policy, Ethics and Life Sciences Research Institute. And I was there for nearly 10 years. And then I went to WHO. And I went to WHO, and as soon as I started there, really, I had a spinal cord injury. So I was in Geneva, and I was obviously not well. And so I flew back to UK, and I got treatment there. And as soon as the treatment was over, I went back to WHO, and I was there for 5 years. And while I was there, we did this World Report on Disability, which was really important because I will talk about the policy, the Convention on the Rights of Persons with Disabilities. But the WHO World Bank World Report was the definitive guide to disability. It had chapters on health, and rehabilitation, and education, and employment, and accessibility, and it was designed to show what could be done. Well, after that, I came back to UK, and guess where I came to? A medical school. And I'd worked at WHO for 5 years, and it's all about global health. I thought all that I've done in the UK up to this point has been about UK, about British people's health. But actually, UK is a very, very rich, privileged place. So I do work in Africa. We did a project called Bridging the Divide, which I did with Nora Gross at UCL. And it was very much, it was working in Uganda, Kenya, Sierra Leone, and Zambia. And I had been heard such messages about disability in Africa, like it was a real, not a disaster, but real difficulty. There was so many problems, and everything I'd heard was about bad things. And I thought, well, actually, all the disabled people I met from Africa through WHO have been very positive, inspiring people. So I deliberately went out to find successful people with disabilities in Africa. And I interviewed them. In fact, we together interviewed 105 people. And they were disabled people who told me about their lives, maybe shopkeepers or maybe as civil servants or teachers or whatever else, and how they had survived, not just survived, but also thrived, how they'd enabled their children to go to university, and so forth. So there were success stories by any metric. And after that, in 2018, I came to London and I worked at the London School of Hygiene and Tropical Medicine, as you know. And here I have done, with my colleagues, a project called PENDA, which was with a dear colleague of mine called Hannah Cooper. PENDA is all about, look, let's find out if interventions to improve the lives of disabled people, the sort of things we see all over the world all the time, let's find out if they actually work. And the only way you can find out is to have a bunch of people who go through that intervention and a bunch of people who do not, and find out by the end of the intervention, are they better off? And so we've done 15 of those. So that's been really impressive. And through Succeed, we've also done what's called a randomized controlled trial in the same way, but it's particularly with people with psychosis in Zimbabwe, Sierra Leone, Malawi, and Nigeria. And we've been trying to find out if we can develop a peer support methodology which is really successful and good for people. And that's what we've been doing. So enough about me. You've heard too much about me. I mentioned before the 2006 Convention on the Rights of Persons with Disabilities, and I want to take that as the first point of my timeline. I've also mentioned the 2011 World Report on Disability, and I want to place that as the second point of my timeline. The third is what's called the Confidential Inquiry into Premature Deaths of People with Learning Difficulties, CIPOLD, C-I-P-O-L-D. And this is a UK inquiry which found that most of these deaths, or a very high proportion of these deaths, were preventable. They were preventable because of better healthcare. If people had received what they needed, they would not have died early. So that was really important because it brought up this issue of people dying prematurely and put a spotlight on that. So it's led to regular data-led inquiries into premature deaths. In 2019, my colleague Hannah Cooper and with other colleagues founded the Missing Billion. And that refers to the idea that there are a billion disabled people who are not getting the healthcare that they need. And so they've done a series of reports, which I'm quoting from, and they are a really important resource. And so if you Google Missing Billion, you will find out. You can Google any of this and find out. And finally, we have now the Lancet Commission on Disability and Health. And you know about the Lancet, the premier medical journal in the world, will have a series of commissions when they think there's something important which needs the spotlight shone on it in a much bigger way. And again, Hannah Cooper has led this, and a number of us from all over the world have been contributing to investigating data about healthcare inequality, investigating the economics, what is being wasted and what could be better spent, and also investigating the political dimension. Why, if this is such a scandal, is it not better being solved? So that was my timeline. I would like to talk to you about some numbers, because so far I have just been giving you words. Well, I'm going to give you a whole series of numbers, and that's why PowerPoint would have been better, but you will get the PowerPoint. So people with disabilities are 3 times as likely to have diabetes, twice as likely to have HIV/AIDS, twice as likely to be malnourished and die in childhood, 10 times as likely to be seriously ill as a child, 2 times as likely to be preterm or low birth weight, 50% more likely to be involved in stillbirths, twice as likely to have cardiovascular disease. And then, we can look particularly at women with disabilities. They're more likely to seek care, but they're less likely to get care that they need. 50% less likely in low-middle-income countries. They're less likely to be even registered at birth. They have lower knowledge about HIV prevention. They have a lower likelihood of contraceptive usage. They're less likely to get sexually transmitted infection screenings. They're less likely to seek antenatal care, attend antenatal class, and of having a skilled attendant at birth in a low-middle-income country. They have a lower likelihood of key cancer screenings such as mammograms and other pap tests in both high-income countries and low-income countries. So the numbers are really bad. Now, what are we going to do about it? I'm going to give you a series of developments which try to do something about that. The first I mentioned, the Convention on the Rights of Persons with Disabilities. And that came into force in 2008. It was drafted and accepted in 2006, and it has an article on health. So Article 25, it's about the highest attainable standard of health without discrimination. State parties, that is states which have signed up to the convention, shall take all appropriate means to ensure access for people with disabilities and health services that are gender sensitive, including rehabilitation. So, including sexual health. And I think the problem with sexual health and disability is that many times people think that disabled people don't have sex, don't have sexual needs. And it's really important to say, no, they're just like everybody else. Of course they do. So I'll go on to our world report, which will help understand some of these a bit better. But it's basically care of the highest quality. That's what we're calling for. So in the convention, it does say quite a lot about health. But in the world report on disability, we said a little bit more because we want to provide some of the data. So, for example, first of all, we made a distinction between what people, their primary disability, for example, a person with spinal cord injury, right? They've broken a back either through road traffic accident or falling from a tree or whatever. So their primary disability, their secondary disability, so pressure sores, urinary tract infections. So those are, so for example, this week I've had a UTI. I would not have that if I was not a wheelchair user. So it's a secondary to my primary disability. And then there are comorbidities which have nothing to do with your primary disability. So for example, people have a risk of HIV/AIDS or depression or whatever else, which is not to do with being for example, in my case, a wheelchair user, a spinal cord injured person. So it's primary disability, secondary disability, and comorbidity. And we want everything to be well responded to by the healthcare system. We want to have regular checkups for people with primary disability. We want to have awareness that they're more likely to have secondary disability. And we also want them to be screened, I don't know, for let's say cancer or for anything else, which blood pressure, which everybody else would have. So that's the distinction that we made. What we did in the World Report on Disability is to look at the World Health Survey, which was something like 60,000 people around the world. And we were able to disaggregate disabled people from everybody else. And this is what we found. We found that people with disabilities are twice as likely to find healthcare provider skills or equipment inadequate to meet their needs. They're 3 times as likely to be denied care, and they're 4 times as likely to be treated badly. So the data is not good. There's a lot we have to work on, a lot we have to change. And of course, in many parts of the world, you have to pay for healthcare. In UK and some other countries, that you don't have to pay at the point of use. For example, when I got my antibiotics for a bladder infection, I did not have to pay for that. But in many places, I would. And that would, overall, looking at the World Health Survey, disabled people have a 50% higher risk of catastrophic health expenditure. Now, what is catastrophic health expenditure? It sounds bad, doesn't it? Well, that's because it is. It's expenditure which drives you into poverty. So if you're living in a poor country or America without healthcare insurance and you have a disease or a disability, you are 50% more likely to be pushed into poverty. And I think that's a really bad statistic. So I mentioned SIPOLD above, the confidential inquiry. And at the time I mentioned it, I thought, well, I need some more data. I need to be able to quote from it. So let me tell you what SIPOLD in 2010 found. The confidential inquiry found nearly a quarter of people with learning disabilities in their study were younger than 50 years when they died, with women dying on average at a younger age than men. Now, I'm 60. I've got many friends who are 60 or above. None of them, or a quarter of them, would not exist if they had learning difficulties. They would have died, which is a horrible thought. SIPOLD also reported that up to a third, 1 in 3, of the deaths of people with learning disabilities were from causes of death amenable to good quality healthcare, so that they could have been addressed by better healthcare provision. And it led to a national mortality review program for people with learning disabilities. And so, as I said at the time I mentioned it, it really drew people's attention to the problem. So there's been more data and it just reveals problems. So let me move on. So what are the barriers to disabled people getting equal healthcare to everybody else? Well, we can talk about the near patient barriers, right? So the near patient barriers, I would say, include, I'm sure there are more, but include travel. So can you travel to the clinic? For example, is there a clinic? Is it accessible, the transport? Does it cost too much? So is there a bus? Is there a train? Is there a taxi, which you can get into with your disability at a price you can afford? So there's that travel. That's the first thing. Secondly, and a huge area, the attitude of medical staff when you turn up. Because you're just another patient, aren't you? You want to investigate or to treat a problem. But the problem is, if you have a disability, if you're a patient with disability, you have the danger of diagnostic overshadowing. So they might explain all your healthcare issues with the fact that, she's got psychosis or he's got Parkinson's or whatever, when it might be nothing to do with that. So diagnostic overshadowing is a major problem, explaining everything with reference to a primary disability. A second major problem is infantilization. So when you're treated as if you can't speak for yourself, when perhaps your friend or family member is asked questions, not you, when the language is less appropriate for an adult. So I think that is a major problem for many people in many encounters. And thirdly, what my friend Caroline Bowditch said to me, or said to the people she was training, she was saying, the problem is that many medical staff want to know, not need to know questions. So we want to have need to know questions. So questions that will make a difference to understanding our healthcare or solving our healthcare problem. We do not want to know questions because those are intrusive and inappropriate and they should not be in the encounter. I remember when I was at WHO, I met a friend of mine, Suzanne. She was involved in women's health worldwide. And she told me the story of a woman from Mali. And she was going to the hospital because she was heavily pregnant and she was about to give birth. And she was in a wheelchair. So she turned up at the reception of the hospital, and before she got any medical attention, which obviously somebody in labor would desperately want, they laughed at her. They said, "How did you get pregnant? You're not meant to be pregnant. What was that about?" So they found it very funny that she was about to give birth. She just found it very urgent. She needed medical attention. So there's all those attitudes which are potentially an issue or a problem. Another question is accessibility of the clinic. So can people even get into the clinic? And remembering that it's not just about a ramp or a lift or whatever at the entrance, it's also about, are there couches which you can transfer onto? Are there machines which can measure your whatever it is, your X-ray, or can you transfer easily onto? So all of those access questions are very relevant. But of course, access is not just about physical access. It's also about things like signage. For people with low vision, is it very clear where you're meant to go? For people who are deaf, is it clear that there is BSL, there's interpretation, or whatever your language is? I was thinking of British Sign Language, but of course, American Sign Language or whatever else, Auslan or whatever else, would be much more relevant in other parts of the world. Is that signage available? Can you book that? When you get your package of medication, is there Braille on the packaging? Because, of course, if you have a visual impairment, you might not be able to tell the difference. So Braille is absolutely essential. And I remember I used to do it when I was at Norwich Medical School. I used to do a session for training doctors about working with disabled people. And a friend of mine called Matt came to talk to the folk about being deaf and a BSL user. And he talked about his appointment in audiology. And of course, if you have a hearing issue, audiology is the place for you. So he turned up and he had a time for his appointment, but it never came. Or rather, it came and went. Because do you know how they announced the meeting, the appointments in the audiology clinic? They just shouted the names. So they would say, Matt, or whatever his surname was, Matt. And of course, he was deaf. So he did not hear. So he went home. And that was a waste of time, both for him and for the health service. And so you'd think that people would get that possibly right. Some people, of course, find waiting impossible. We're all used to waiting for healthcare, but some people cannot wait. So it's really important for their time to be honoured and them to be able to get in whenever it is. And of course, some people need longer consultations. So, for example, they may take longer to explain their issues, or they may have more issues. So I think that innovative queuing or non-queuing for people, a regular monthly clinic for people with intellectual disability, for example, an immediate drop-in service for people with autism or other impairments, those sorts of things that are very innovative, imaginative ways of redesigning healthcare so it can be more accessible to people. So yeah, very, very important. As well as those near patient factors, there are wider factors which are relevant. I mean, access to healthcare is an issue for everyone. So in your society, can everybody get the healthcare they want? Because if you have poor access, then of course you will be disadvantaged. Also, stigma. Is there an immense amount of stigma attached to disability or attached to, for example, psychosis or attached to epilepsy or other things? And that includes self-stigma. So even if nobody actually is going to buy you, you may think that you cannot ask for this help because it's so stigmatized, it's so embarrassing, it's so awkward, and it's much more difficult for you. Thirdly, there's health insurance, public or private health insurance. Are you covered? Is that existing? Will it be paid for? Can you get free healthcare, at least at the point of use? Really important. Social protection, the idea that you have a decent standard of living, you're not poor. And wider public and private infrastructure. So can you get into houses and homes? So, for example, when I had spinal cord injury, I spent 10 weeks in a rehabilitation in a hospital for rehabilitation of people with spinal cord injury, and there I got to know half a dozen people who were also, one had fallen off a horse, one had fallen off a push bike, one had been crushed, being a quad bike racer. So yeah, they were the people that I got to know. But when it was time to go home, when we'd learned everything we needed to learn, I was the only one who was able to go home straightforwardly because my home was wheelchair accessible and theirs was not. So they had to wait to, I don't know, build an annex or move house or otherwise get ramps or some solution. It's much more difficult. So lots of near patient and wider factors that make healthcare barriers make healthcare more difficult to get hold of. And I would say this is important also because healthcare is vital to the other rights that disabled people have. And if we want to look at rights, as I said, we should look at the Convention on the Rights of Persons with Disabilities. And there, any of these articles. So, for example, Article 19 is about living independently and being included in the community. Well, that might be much more difficult if your healthcare needs are not met. Personal mobility, Article 20. Well, if you have pressure sores or if you have not got a wheelchair or other mobility device, of course, you're much less likely to be able to enjoy that. And the awful statistic is that only 15% of people who need a wheelchair have it. So worldwide, there's a massive shortage of assistive technology. We can look at the right to education, Article 24. But of course, if you haven't got a wheelchair or splints or a reader or whatever, or a computer with JAWS software, whatever you need, you're not going to be able to learn. And so that is, an education is such a pivotal thing. So healthcare as a way into education is very important. And of course, the right to work. Both when I started my current job, I had to get a mobility device in order to get to work. So I have a wheelchair, that's fine, but I needed something to push that wheelchair so that I didn't have to wheel all over London and have the sore arms, the rotator cuff injuries that would result. And if I don't work, or anybody doesn't work, they don't necessarily have a good standard of living. So you can see why, if you can't, say, work in the fields and grow your food, or you can't make things sell, or you can't go to work and all the rest of it, you're going to be less likely to have money. You're going to be less likely to be able to look after your family. And finally, what do we do the rest of the time? Cultural life, recreation, leisure, sport. None of those are possible without healthcare. So you could really see any of those articles of the convention would be that healthcare is a gateway to all of those. Really important. So I will conclude fairly soon, I think, and then we can have a discussion. So the goal of our efforts to improve is health equity. So it's not quality. We're not saying everybody has to be the same. It's equity. And equity means that we eliminate the social barriers to good health. So anything that we can do to make sure that disabled people have access to the same standard healthcare of other people is our goal. Because, we're not saying that people have to be better. We're saying they have to be as good as. And often, as I've shown you from the data, they are not. So if we want to say, why is this important? I mean, it may stand a reason for you. You're here after all, you must think it's important. But there are three, I'm going to say there are three really strong arguments which we can make for that. The first is from human rights. So right to the US Declaration of Human Rights, health is in there. And it's been in all the articles, all the treaties and instruments and there. So, and obviously I talked to you about the Convention on the Rights of Persons with Disabilities. So we cannot fulfill our human rights without health equity for disabled people. That's really important. Secondly, there's an argument from social development. So we look at the world and we want poorer countries to develop. We want them to be places of where people can flourish. We recognize that they are on the road, but we hope they will get there. Now, they won't get there with disabled people being left behind. And if you think about all of those development goals, sustainable development goals, millennium development goals, whatever they might be, all those targets, we need to include disabled people in those. Because, for example, if we want everybody to go to school, that's great, but it has to include disabled people. So that's one. If we want every woman to have healthcare, safety, security, that has to include all the women with disabilities, and so forth. If we want to have an end to climate injustice, then people with disabilities have to have access to safe systems for emergencies and so forth. So lots of social development arguments only make sense if you include persons with disabilities among everybody else. And in fact, if you make sure that they are also included, because you might think you solved the problem, but you haven't yet, probably. And third and finally, that is to say, there's a huge waste of human capital. That there are so many people who could be productive, who could contribute, who are wasted human beings in terms of what they could do. If only you overcame the barriers which stand in their way. So if you gave them, they were able to get good healthcare, if they're able to get good assistive devices, if they're able to get good physiotherapy, good pain management, all those other things which I'm very glad to see you're dealing with in this great summit on inclusive health. If you're able to get access to all those, then I think you would have less wasted money. And more to the point, you'd have lots of people able to do what you need as a society to develop and thrive. So, for example, they would not need to be looked after. At the moment, there's more carers, but we could say, look, you don't have to care. I'm fine. I'm independent. You go to work. Or their children could be productive in looking after the children or whatever it might be. But the point is that instead of being a waste money, they would be an asset, a huge asset to the economy. And of course, the final argument is one from, I would say it's from morality. It's about suffering, and it's about reducing suffering, and it's about ensuring that people get the treatment that they need in order that they can be the people that they have the potential to be. And too many folk who could achieve such a lot are held back by the way that we fail them. So that's my concluding thoughts, and I'd very much like, I will send my PowerPoint so you can have a copy of this, but I'd very much like to see any questions. So if you, I think if you put up your hand digitally, you're welcome to ask me a question, and then we can carry on with the discussion. So over to you.
Wow, wow. I'm still mesmerized by everything you have said. I know I had some questions, but I feel you've already answered them, and we really appreciate that very, very powerful opening keynote speech. Thank you so much for that profound and thought-provoking address. Those insights,
Thank you, Sam.
yeah, they've just reminded us a lot of things that we sometimes ignore or assume. And I'm really, really glad to hear in your last comment where you emphasize that we having to include persons with disability, especially in social development.
I think,
yeah.
I think
Yes.
hearing from disabled people in all of the sectors, whether it's social development or whatever, in the church, in the temple, in the mosque, in the home, in the village, disabled people are wise, not always, but often. They certainly have the same access to wisdom as everybody else, if not more. And therefore, we should try and make sure we learn from. And
Yeah.
I think that's very interesting, the idea that we should learn from disabled people, because disabled people are used to being treated as if they have nothing to say, as if they have no opinion, as if they could not be, should not be consulted. And yet, we all know so many disabled people who, whatever their profession, do contribute massively to their world. And that's whom we must support, honor, include, and answer when they have things to say. So,
Yeah.
any questions?
Anybody with a question? I saw somebody had asked a question earlier. What did she say? Rose Waringa, is there an age of consent to sex to a girl with disability above 18 years when it comes to legal rights? I imagine
Well, I
that
think,
applies
yeah,
countries.
I think generally speaking, the age of consent is the same for people with and without disabilities. However, there is an important consideration, which is, does the person have capacity? Are they able to understand, to remember, to recall, and to repeat, and to answer? And if they do not have capacity, and some unfortunately people do not, then there is illegal in most jurisdictions to have sex with them. So it's less about their age, but also, so for example, if some lady was inebriated, if she was drunk, then if you had sex with her when she was drunk, she would not really have said yes. She would be out of her mind, whether it's drink or drugs, and therefore it would be rape. And the same applies to many, not all, but many folk with issues of capacity. So I think they would have to decide. And the fact is that sexual violence against disabled people is high. Violence against disabled people is high. And we need to understand that and to respond to it. So thank you very much for the question.
Yeah, so John says, absolutely inspiring presentation. Sir Thomas, would the LGBTQ community be considered under the disability framework?
No, well, I mean, being lesbian, gay, bisexual, transgender is not a disability, of course. But certainly there are lots and lots of persons with disabilities who are LGBTQ. And we must, so for example, we must be aware of that. So we must not slip into heterosexist or even homophobic ideas that they're not welcome or that that's not possible or that's not what people do. So I think I would hope we're able to give advice to people whether or not their partner is the same gender or a different gender.
Yeah.
And we need to make sure that we are aware of people's other identities. I think they're not disabled because of LGBTQ, but they might be, as it were, it might make their life more complicated and it might make their difficulty in finding a healthcare provider more complicated. So, for example, many disabled people in UK would rely upon a carer. They would rely upon somebody to come to the house and maybe help them out of bed or maybe help them to food or maybe whatever. That's what carers do. Now, if somebody is, carers are often not very well paid, often they're often migrants. So they may, some, not all, some may have conservative attitudes. So imagine you're a gay man or a lesbian woman or whatever, you have a same-sex partner, but you also have a carer. And imagine if they start preaching to you that this is wrong, sinful, you're going to go to hell, or whatever else it might be, because of their Christian, Muslim, or other background. I don't think that'd be acceptable. I think you should be able to get a carer who does not impose their morality on you. And I'm afraid, this is not a made-up example. I'm thinking of a real example. And the same, I think, should be, lots of healthcare workers are inspired by their faith. And I applaud that and I welcome that. And they're very welcome. And thank goodness for them. However, they should not impose their morality when it comes to it on their patients. And most 99.9% do not. But occasionally they do, and I believe that is wrong.
Well said. I have a question for you. So the World Report on Disability has transformed global conversations on inclusion, like you've mentioned some of it. 15 years later, what progress are you most encouraged by, and where do you believe we are still falling short?
It's difficult, isn't it? It's more than 15 years later because we published it in 2011. So the World Report is now more than 20 years old. It's a very old document. So we need to update it, and it is being updated. What it encourages me, I think the improvements in access. So when I first started traveling around the world working for WHO, yeah, it was not easy to get, for example, onto planes. So to get around buildings or hotels or meetings, or whatever, it's not easy. Well, now it is easier. There's more awareness. There's more inclusion. So I really welcome that. I also welcome the fact that many brilliant disabled people are shown a way. They're showing what can be done. So what I didn't mention in my talk was the disabled people's organizations. So, for example, there is IDA, the International Disability Alliance, which is an alliance of disabled people's organizations, which may be there for deaf people or people who have physical impairments or people who have sensory impairments, hearing or sight, people who have intellectual impairments, and people who are survivors of the mental health system. So IDA is really important because it brings together the voice of disabled people worldwide. And there will be groups in all these countries. And I think it's really important to find a group and work with them and make sure that the innovations you're developing are appropriate. Because we all know about well-meaning but inappropriate interventions. And I love Turkey, and I don't want to be negative about Turkey, but let me tell you one thing. I remember when I was about 10 years ago, so there was a big drive to make Turkey more accessible, which I think is great. I don't have a problem with it. I think it's great, and it's probably got a lot better since. But at that time, what they did was they said, "Oh, we've got ramps everywhere." And I went and I found out that what they'd done is they'd taken a flight of steps and they'd put concrete over it. So it was the same pitch as the steps, but it was now smooth. It was able to be traversed. Well, it was able to be traversed if you were Goliath, if you had immense strength, because of course the steps are far too steep for a wheelchair user to traverse up steps. It's true that with a push you may be like it, but it did not fill me with confidence. And that's not the only place. There's lots of places in the world which have tried to help but have not succeeded. And I think the answer is to listen to disabled people. And if you listen, you'll find out what they need and you'll be able to provide or negotiate to provide what they want.
So there's a question here from John. Is there any estimate of the disability burden in the global south relative to the overall disability burden?
Well, I mean, we know that 4/5 of disabled people live in the global south. So whether we say it's 1 billion, 2 billion, whatever, 4/5 of those live in the global south. But I'm not sure that that is a surprise to us because 4/5 of the world's population live in the global south. So I don't think that is, remarkable. We might say that people in the global south don't necessarily live into old age. Some do, thank God. but many people die prematurely. All people, not just disabled people. So what we might say is that in the global south, there is a high incidence of disability, but the prevalence is not necessarily any higher than in the global north. What I'm saying is that many people are born with disability, but maybe not surviving into old age. And therefore, the numbers of disabled people are not necessarily higher. So, yeah, it is more of a problem. I've been to, as I say, I've been to lots of countries.
Yeah.
One of the things we've been trying to do is to improve availability of assistive technology, of wheelchairs and so forth. So, for example, we were working in Cameroon, and I'm not sure if there's anybody here from Cameroon, but we were providing wheelchairs to people. And I think that's great. Wherever you are, the wheelchair is very good. It enables you to move around your home and your community. But the problem is in Cameroon, it's a very, very hilly place, certainly where we were working. So whereas in, say, Australia, a wheelchair would have enabled you on a tarmac road to go everywhere, in Cameroon, it didn't enable you to go very far at all. So I think, yeah, there are issues which we can't do anything about, which is about the terrain, about the heat, about the sand, and other factors which make life much more difficult. So yeah.
So a question from Robert Hill. 2 weeks ago, an X-ray facility in Central Florida refused to take my X-rays because they declared me non-ambulatory, even though just over a year ago they had taken my X-rays in my wheelchair. How are they allowed to refuse me based on an internal policy?
Well, you're in Florida. That's covered by the Americans with Disabilities Act, and I would say that was illegal. I think they violated our rights as an American citizen, and I hope that somebody takes up that case pro bono and says to them, you can't just discriminate against this gentleman when you took, you've got a good case there. So I hope that somebody in Florida hears this and takes it up.
Yeah. So a question from one of our members, Mark Stoddart. In the UK, the number of people claiming disability benefits has risen significantly. With working age disability benefits are forecast to reach £25 billion by 2027-28. Why do you believe there's such a significant increase?
I don't know. To be honest, I don't know. We're studying this at the moment. We're looking at social care and what's called PIP, which is the benefit. And we need to find out why there's been this increase. But I think increases often reflect wider economic issues. So, for example, in the years when Thatcher was Prime Minister, disability benefit rolls rose. Why did they rise? Because many men in their, say, 50s were being made redundant, or their factories closing, or there's no coal mine, and therefore, rather than putting them onto the unemployment register, they were likely never to get a job, so they're put onto the disability register for benefits that way. So I don't necessarily think, for example, that it reflects increase. Having said that, we are all aging societies. So Britain is the same as anywhere else, or more so. So it may be that more people are coming to that category and claiming that benefit. But I think, yes, you're right, it should be investigated. And the practices which are channeling people towards that as an option need to be, I think, because I think disabled people should be productive, can be productive. So anything that promotes that is good.
Somebody just made a comment here. Ramu Kaladi says, why are we calling it a disability burden? I thought we are trying to remove the stigma of disability as a burden.
Well, I mean, yes, we are trying to destigmatize disability, but I mean, I can tell you, I have had a UTI week. It was a real hassle. So I think we have to do two things. We have to say disabled people with disabilities are valid, viable, welcome. We must support and include people with disabilities at all times.
Yeah.
But we need also to have space to say disability is sometimes a pain, if you'll forgive my language, in the butt. It's something you can live without. And so I think burden of disability is a very stigmatizing term. I'm sure it's not meant in that way, but the fact is that having a disability is a problem. We teach people to look both ways while they cross the road. There was a wonderful sticker that I got from South Africa, from the Quad Para Association of South Africa, and it said just this. It said, "Buckle up," meaning seatbelt, because we don't want new members. So they were involved in the prevention efforts. So I do think prevention is good, and at the same time, we need to honor and include all persons with disabilities, because we owe it to people to include them, not to prevent them.
Yeah. So I'm just thinking, for me, this is my last question because I can't see any other questions here. But if every Rotary Club in the world committed to one action to advance disability inclusion over the next year, what should that action be and why? Majority of us here are Rotarians.
Yes, I know. And Rotary is so powerful and so welcome as a friend. I think the Rotarians are often very prominent in their local communities, and they have so much influence. And I would think that all these communities that you come from throughout the world, can we talk to our council members? Can we talk to our mayor? Say, look, we want our city, our town, our village to be a model of inclusion. We want to make sure that we are known for where disabled people are welcome and where the terrain or the facilities are accessible to them. I think Rotary has so much influence through ordinary communities. So I would say that nothing special, nothing exciting. Just do what you do and always remember persons with disabilities.
Thank you so much. Thank you for inspiring us. Thank you for just giving us these thought-provoking ideas in our heads. It's nice to listen to somebody like you. You're one person whose voice is very powerful, but I know all of us can do something. Yeah.
It's a great privilege to be here. I will send my PowerPoint to Kemason, and I hope he'll be able to circulate it. I'm sorry, my fault on not being able to show it to you today. I assure you there weren't any pretty pictures, so you didn't miss any content. You got everything I would have said. All right. Thank you so much, and good luck in your work.
Thank you so much, and have a lovely day. All right. We are now done with the keynote speech. Everybody, I hope you're feeling inspired, you're feeling excited. I'm almost jumping out of my chair after listening to our keynote speaker, Professor Sir Thomas Shakespeare. We will move on to our second panel session. Sorry, not second, but it's our first panel discussion, which explores a fundamental question. How do we transform policies and commitments into real meaningful change in people's daily lives? Because we know that healthcare accessibility must move beyond just legislation and strategy documents to become a lived reality for every individual. So our panel, which is a very distinguished panel, will share insights, experiences, and practical approaches for turning vision into action. Moderating this very important conversation is Simran Main from Kenya, who is a passionate humanitarian and public health advocate, actively serving with the Lions Club International Foundation and collaborating with the World Food Programme on initiatives that improve school feeding infrastructure and community well-being in Turkana County. She's also a respected researcher and co-author of studies examining the socioeconomic factors that influence chronic disease management in rural Kenya, bringing valuable insights at the intersection of health policy and community development. Please join me in welcoming our moderator, Simran, who will introduce the panelists for this session titled Healthcare Accessibility from Policy to Practice. Over to you, Simran.
Thank you, Som. Good morning, good afternoon, and good evening to the audience and everyone listening over. That was a really huge introduction, Som. Thank you very much. I will take this opportunity to introduce my panelists for the session. I will start with Dr. Majid. He is the Associate Dean for Research and Innovation at Strathmore University Business School and a senior lecturer with over 30 years of leadership experience in the healthcare sector in Kenya. His expertise does include healthcare management, strategy, quality improvement, operational excellence, and organizational change. But apart from this, Dr. Majid also holds a qualification in medicine, management, and law, including specialist medical training, an MBA, a DBA, and admission as an advocate of the High Court of Kenya. He is also a certified mediator, arbitrator, and executive coach. Dr. Majid has served on the board of trustees at Strathmore University Foundation and continues to contribute to the healthcare leadership and innovation. I also have Mumbi. Mumbi is the head of Global Inclusion World Food Program. She leads initiatives to advance inclusive practices across global humanitarian operations with a strong focus on disability, inclusion, and accessible workplaces. She holds a background in psychology and a Master of Science in Organizational Development. She is highly recognized for translating inclusion policies into measurable organizational impact, and she champions leadership, accountability, and inclusive design. As a panelist of this summit, she will share her expertise on healthcare accessibility and inclusive systems, and above all, she credits her role as a mother with shaping her empathetic and purpose-driven leadership. Thirdly, I do have Patricia Mills. Patricia Mills is from Australia. She is a highly experienced registered nurse with an extensive career spanning rural and metropolitan healthcare in Australia. She has served in clinical, management, and executive nursing roles, including leading teams of over 115 nurses across multiple states before retiring in 2013. Since joining Lions, she has held numerous leadership positions, including district governor. She is a passionate advocate for community health, playing key roles in the Victorian Lions Skin Cancer Foundation and leading diabetes awareness initiatives across Lions Australia while coordinating major health education programs nationally. Last but not least, I'd like to introduce Lions Sir Tony Benbow, who is an OEMGP in Australia. He is currently the third Vice International President of the Lions Clubs International, where he began his journey in 1985 as the charter member of the Lions Club of South Vermont, Australia. Over 4 decades of service, he has held various leadership roles, including zone chairperson, cabinet treasurer, vice district governor, amongst many others. The list is long, Tony. In July 2025, he was elected the international vice president. But beyond that, Lion Tony has enjoyed a distinguished 40-year career in Australia in the banking industry, serving in senior executive leadership positions. He's also chaired several Lions foundations, and him and his wife are Progressive Melvin Jones Fellows, and they have received numerous rewards in recognition of their outstanding service to Lions and the community, including advocating for people with autism and the disabled within the community. So thank you for being on this panel. We totally appreciate this. I'm going to start off with an icebreaker for all of you before we go on into our session. And please feel free to go first. From your experience in Australia, Kenya, and Italy, and the global humanitarian setting at large, in one sentence, what does patient-centered care mean to you? Dr. Majid, would you like to go first?
Point of view. Yeah, I'll throw in for the first one. Thank you, Simran. I think, when we start to look at patient care, it's got to look at outcomes. And I think from our perspective, delivered care has to meet the patient's need. A simple but outcome that's got to have the priorities that we look at.
Thank you. Let me chip in from there. I agree with Tony 100%. We can add more to that. Patient-centered care, most of the time we look at it from the institutional point of view, and that tends to be a little bit paternalistic or paternalism type of approach. I think patient-centered care is from the patient point of view. When you look at the definition of highest attainable standard of health, acceptability is one of those measures. So it needs to be care that is acceptable to the patient, especially when you're talking about disability. That's my take on patient-centered care. Thank you.
And if I can chime in, because I'm coming in from a workplace perspective, for us, patient-centered care, whenever we are looking at our employees, means living our commitment as the World Food Programme to leaving no one behind. So we ensure that people with disabilities shape access and benefit from their assistance with dignity and without barriers, because our work is solely on ensuring that whoever we are giving food assistance, their needs are met. So using an equity lens whenever we are having aid distribution. Thank you.
Sorry, Patricia, you're
Pat,
muted.
you're on mute. Yes.
Patient-centered care means being able to everybody to be able to access care when they can, and I think regardless of whether they're disabled or not, I think that it's very, very necessary for people to be able to just access the care and and know where to access the care as well.
So Simran, allow me to just address this a little further.
Sure.
Speaking from Sir Thomas's discussion, I really loved the discussion. We need to look at patient-centered care. That care does not start at the hospital. And that's where we tend to focus on the patient-centered care. And I feel that is missing opportunity. By the time the patient has fallen sick and is not able to get into that public transport, we've already missed on the patient-centeredness. When we have a wheelchair person heading to the hospital and the pavements are rough and with potholes, we've missed the opportunity for patient-centered care. So we need to look at patient-centered care in the continuum of care, in the ecosystem of care, and not just focus on hospital-based care. Thank you.
So building on to Dr. Majid, your question, you're basically saying accessibility needs to move beyond physical spaces. So what are the less visible barriers that patients with disabilities face when accessing healthcare?
Let me build on that then for just a few seconds. I think we need, first of all, one of the most visible barriers is to move beyond just physical disability. When we have an patient suffering or patient with albinism, the sunlight, especially being in an African country, is already hindering that access to care. So we need to look at it from 360 degrees of the person with disability. Now, even in some countries, even my bald patch would be considered disabled because I would get kidnapped and somebody opens up my skull to look for gold. See, so we need to look at it from that point of view. It sounds light until it happens to you, because this happened in one of the East African countries. So if we to look at disability, physical, environmental, and we begin to see that I think our own how do I say, myopic approach to disability is one of the biggest hindrances to availing care to the disabled. Thank you.
Mombi, would you like to add on to that?
Yeah, I'd just like to add, based on an employee perspective, because WFP works in over 123 countries and territories across the world. One of the things we've seen, because we work in the most challenging context in the world, is stigma. And this stigma is based on those operating contexts, because what we see is that like was said earlier, most of the people who have disabilities live in the developing countries, right? And that is where we operate. So we find that stigma makes people not go and seek any help whenever they have disabilities. And also what we've seen, and from my personal experience, is systems are not designed with diverse needs in mind. So which can leave employees navigating care on their own, right? So they don't have a support system where they can go seek that care. So the way we build in a world that is built not having people with disabilities in mind can often lead to them navigating those spaces by themselves. So from an organizational perspective is what is it that we can do to ensure that the people that we say people are our most important resource. So how do we ensure that the people who are our most important resource are serving the people that we serve? How are they going to be able to serve the slate of needs that we are assisting out there? So ensuring that we reduce the stigma and also building and designing the systems with everyone in mind. That is what we've seen can mitigate the barriers that we often see. Over.
Thank you. Tony, Pat, is there anything you'd like to add based on your expertise?
I think, sorry, Pat, go ahead.
No, you're right, Tony, go.
I was just going to say, I think I, confer completely with Dr. Mujeeb in terms of that process and the understanding, and what Mumbai said is really critical. It's got to look at the individual, and it's got to look at the resource available to it. We can't have that stigma that goes with it. It's got to be much broader than it, and it has got to look at it as being, fully encompassing when we look at the support that's needed. Thank you.
No, I think I agree with everything that everybody said, and I think accessibility is probably one of the most important things that we have to have. And I think listening to our keynote speaker, who spoke quite a lot on accessibility and being able to get into places and having ramps available and all of those sort of things. And I think that really is very, very important to people to be able to access and be able to go to places where they need to be going to. And I think Mumbai, I'm just most impressed with you talking about stigma. I think that we're working with that at the moment, and I think that's something I think that really needs to be brought to the forefront more. And I think congratulate you for bringing that up, because that is sensational.
Thanks. Thanks, Patricia. So I now want to move on to the essence and the core of our session today, which is moving from policy to practice and advocating for this. And I just want us to spend a bit of time on this with all your expertise, where each of you as panelists come from various countries and sectors, and a lot of countries and organizations do have policies that support inclusive healthcare. But from your various perspectives, why do implementation gaps persist, and how do we bridge the divide between policy and everyday practice?
Maybe I could start this time. So from what I see, and obviously because I'm looking at this from an employee perspective, and I was just listening to everyone's credentials and I was like, wow, this is amazing. However, I think why these implementation gaps exist, and actually even from what we do, number one is because we don't involve the persons with disabilities. So whenever we are making decisions, or we are, for myself in my organization, whenever there's policies being drawn or reviewed, you're not including, we don't often think about the diverse slate of people we have, of employees. So if you don't include persons with disabilities in the policy, you're more often going to find that there's gaps in implementation because, number one, they're not involved. So whatever you're implementing is not catering to them. And secondly, there's a lack of awareness. The world was built for people who the world calls normal, and I'm saying normal in quotes, right? So it wasn't built for everybody. Whenever we are thinking about the various dimensions of diversity, thus implementation gaps will exist. And also a fragmented approach in terms of inclusion. So when we think about diversity and inclusion, more often than not, people will look at the gender aspect, right? Male, female. We are not thinking about the intersectionality of the various other aspects, whether it's people with disabilities, people who are LGBTIQ+, all the dimensions of diversity, we don't look at that. And specifically, if we are not looking at persons with disabilities, then we are not going to build a world that caters to both the non-apparent and apparent disabilities. So in our case, it's as an organization, me as leading the global inclusion is a true focus on where is it that we are missing out? Where are we not including every single person? If at all, inclusion is one of our values, by the way. So if at all we are going to truly come away as an organization that's inclusive, where are we missing the mark and how can we do better? So I think those are some of the gaps that I've seen from my own experience. Over.
Dr. Majid, Tony, Pat, anyone?
Okay, okay, Patricia, you look like you want to say something. Let me allow you to go first.
Now, what I was going to say that in our area within Lions, in the area where I am in Victoria, we have all abilities Lions Club. Now, when we started this Lions Club, a lot of the people who joined us on the spectrum, and they were very markedly not being able to do the things that they could do. We sort of said to them, it's all about your ability, not about your disability. So we've seen a growth in the people who have joined the Lions Club, and what we've been able to do for the people who are on the spectrum. It's been absolutely amazing what we've been able to do to enable them to actually get jobs. One person recently has been promoted in his work, and I think that I was talking about it before. It was about accessibility, and I think this is the thing that we need to do. We need to encourage people to get out there, and we need to encourage people to join in with what we're doing, and also we want people to say, what can we do to help you? And I think that's really, really important.
Thank you.
On what Mundi said, when we are looking at involvement of people with disability in decision making, I want to challenge that we go further than that. We need to look at the entirety of the ecosystem in dealing with any type of disability. We need to look not just at the patient who comes to the hospital who is disabled, but the person who also takes care of that disabled person. And their points of views also needs to be taken into consideration when you're translating policy to action. What do I mean by this? When a nurse is struggling to lift the patient from a wheelchair onto the bedside for examination or to the stretcher, that means that particular design is not appropriate. So if we don't listen to that nurse and saying she is having a problem, so we need to look at the entirety, and everybody needs to contribute to it. So I agree 100%. The voice of the disabled is absolutely important, but so is the voice of the entire ecosystem. So we need to look at that. Then also the comprehensiveness of the definition of disability, I feel, is contributing to the lack of progression of from policy to action. By this, I mean, we don't see, whenever we talk about disability, the first picture that comes to mind is physical disability. But we do have a big spectrum of disability that requires to be taken care of. Can you imagine a blind person giving consent for surgery? How do they sign the consent? So if we don't think of it, how do we deal with a patient with autism who requires reduced sensory input for them to become so that they can make a reasoned decision? How do we reduce that patient, remove them from a very noisy casualty environment or accident and emergency environment? So unless we think of it holistically, in Kenya, we have excellent policies. We have excellent laws. One of the biggest things that retard progression from policy to action is this statement of progressive realization, that we are not able to do everything in one go, so let's do it progressively, which is a synonym of doing nothing. So we need to then set out the specific milestone of what progressive realization is. Progressive realization has to move from 1 to 2, 2 to 3, 3 to 4. We cannot use progressive realization as a reason for doing nothing. It's very Kenyan specific because that's the environment I'm aware of, but we've been using this repeatedly. No, we can't realize this because we are still working on it. 20 years later, we are still working on it. Thank you.
Thanks, Tony.
Thanks, Simran. I think Dr. Majid hit the nail on the head, if you like to call it that way, in that way. And I think also too, when we start to look at things, and I can say from a local perspective, and Pat can comment here as well, we find that the system drives the outcome, not the individuals and the support processes behind the individual needing the help and the assistance. It's a reverse process. We've got to try and change it to become much more, if you like to call it, patient focused, not system focused. Whereas the system is too designed to, well, if you fit into this box or this box or this box, that's what you're going to get. We've got to change that attitude. And I don't know where that fits in other areas of the world, but from a local perspective, it becomes very system driven, not looking very much on an individual patient basis and adapting the needs and the qualities that are needed to assist those individuals. And that, potentially, in terms of organisations going forward, is where potentially we may have an opportunity at the community level or organisational level to try and have influence. Thank you.
That just leads up to my next question of who bears the greatest responsibility for ensuring that these policies actually translate into action. And you've kind of just answered that to a certain extent, Tony. Mumbi, in your part of the world and in your organization, because you look at it from a workplace perspective, how does the UN or the World Food Programme or your organization actually bear up this responsibility? And is it a collective responsibility? How does this work?
Thank you, Simran. And I'm going to just respond to that based on what Dr. Majid has said. So for us, because we need the policy guidance, right? And you've said about, some things remaining as, you have to progress in order to progress. So for us, we are guided by the United Nations Disability Inclusion Strategy. And this is a document where there's various performance indicators and various business owners own particular indicators. For example, I own all the performance indicators to do with reasonable accommodation, employment of persons with disabilities, and capacity development of those. So there is what I've seen to be totally useful and what makes sure that we are doing what we ought to do is those performance indicators are graded. So you're either approaching, you're meeting, or you're exceeding. So every year there's the organizations, all the United Nations entities, funds, programs, they are graded on that. So whenever there's guidance from the Secretariat, unfortunately, sometimes people need that push, then you find that all the organizations are going to participate and they're going to move towards ensuring we have disability inclusion and that it's everyone's responsibility. What helps us also is a management that is very bought into what we are doing in terms of inclusion. So I could go straight to the executive director, the deputy executive director, and say, I need us to do A, B, C, D so that we can be more inclusive. So inclusion is not just performative for us. It's something that we absolutely uphold. It's one of our values. We have inclusion, commitment, humanity, and the rest. Therefore, we don't want it to just be a placard on a wall. It's something that we practice every single day. And if it has to do with me, obviously, I'm very passionate about it, not just because it's a job, it's something I care about. And also setting aside budgets for this work is critically important. And that's what we've done. We have a centralized approach to disability inclusion where, because we work in all these countries and each country is basically, the country director is a CEO of their country. Sometimes you don't have funds to facilitate disability inclusion. So I hold the budget in headquarters so that this is accessible to everyone equitably. So there's no country that's going to say, we don't have funds for this. So it's a centralized approach. I can speak a lot about it, but I'm going to give the other panelists an opportunity. If I start, I'm passionate about it, I could speak all afternoon, but we don't have all that time. So thank you, Simran. I appreciate it.
Thank you, Mobi. Dr. Majid, from a Kenya perspective, what would you say in terms of bearing the greatest responsibility? Is this a collective decision? I know you mentioned that it's not just about the patient, it's also about the carer. But what else? What about the governments? What about development partners and communities like Tony mentioned? Or are we looking at all of them?
Yeah, the last word you mentioned is what I firmly believe in. We're actually looking at all of them, and we need to be responsible at individual level and therefore at community level. I'm using the word therefore deliberately because there is no community without an individual. So when we say, is it responsibility of the government? But the government is us. So we need to hold our government accountable, and we need to discuss this. I want to be a little bit utopian, a little bit idealistic, and say if we remove standards and say the minimum standard is for a building, for the roadside, for the vehicles to be able to accommodate the disabled person, we would automatically have met the standards for everybody else. So you can imagine if the building, we are able to have the physically disabled, the visually impaired, the hearing impaired standards already included as minimum standards, then there would be no other standards because you would have surpassed every other standard. But if we set the others normal standards and then have an inclusion as an added on, I feel that would limit. But I appreciate I'm being utopian. But for me, it sets the tone that it's all our responsibility to have standards that are inclusive as a normality. That's our way of life rather than as beyond and above. Thank you.
Pat, thanks, Dr. Majid. Pat, do you have anything to add to this?
Probably nothing to add, but I want to reinforce exactly what Dr. Majid said and Tani has said about community. I think it's exceptionally important that the community has a big handle in, if you like, setting up processes, if you like, and letting people know and making people aware of what the people who have got the disabilities, making people aware, letting people know exactly what is happening to them, because people just don't know some of the time. And what we were talking about before was about the carers. And I think that's really, really important for people to understand that the carers are a priority with a lot of these people. And we have to take into account that the carers are affected markedly by what they're doing with the people in their community. But I think community is a major part of what we have to, and communities have to make everybody understand what is happening in their community.
Absolutely. So when we make a call to action, what can we actually do? Because based on your various experiences, what is the one practical action that healthcare institutions, policymakers, humanitarian organizations, or like we've been talking about the community groups, such as Rotary itself, what should be prioritized in advance? And especially when we look at the theme of the summit, nothing about us without us, as far as even patient-centered care is concerned, how do we look at this as being fully accessible care?
Maybe I can just go because I really like what Dr. Majid was saying and what Pat said. The number one thing that we can do is universal accessibility. Whenever you are talking about, sometimes, we don't have to, there's something you said, Dr. Majid, that made me remember about what we do in our context. So universal accessibility will not only help the person who is a wheelchair user, for example. So whenever, because we are working, as I said, in all these contexts, there's lots of buildings that we have. So ensuring that the building, for example, is already accessible before anyone ever is recruited that has a disability, that's one of the things we can proactively do to ensure that persons with disabilities access all our spaces. The other thing based on that is just reduction of stigma, because there's a lot of stigma around disabilities because, for example, because we work in Africa, there's all manner of things that are, there's connotations of why someone is disabled. So stigma reduction and building, having the universal design and accessibility whenever we are building, those are some of the things I see we can practically and tangibly do. Over.
Thanks, Mumbi.
I think individual responsibility, I like what Rotary Lions are doing. You're not sitting back and saying it's government's responsibility. And Rotary is made up of individuals. Lions is made up of individuals who come together to make a difference. So for me, I think what the rallying call should be, we all need to take responsibility for our action. And the starting point is education. I mean, just what Sir Thomas talked about today was mind-blowing, and it allowed me to reflect a little more deeply. If we could have more of those kind of things, and I consider myself fairly educated and fairly liberal, and yet I was blown out of my mind. Now, you can imagine how much more this will have an impact across the country, from the rural woman in the village all the way to the boardroom CEO type of person. So the entire spectrum requires to be educated on what it is all about. I think with education, hopefully, and I'm saying hopefully, we can then change attitude. And if we can change attitude that disability is all our responsibility and we are all inclusive, then hopefully we start being more responsive and more considerate whenever we are designing facilities, education, hospitals, healthcare, you name it. Then it flows from there. Thank you.
Thank you, Dr. Majid.
I was on my mind talking about inclusivity, and I think that what you just said, Majid, was just absolutely sensational, because I think we must be inclusive at all times and inclusive of everybody. And I think that's what we're noticing in our communities, that the inclusivity is actually producing wonderful results from all sorts of people. You know, I work with a lot of people who are deaf, got cochlear ear implants. I'm working with Vision Australia. We're doing a lot of work with Vision Australia at the moment. We're making sure that they're included in everything that we do. And so that's, I think, yes, absolutely, inclusivity and making sure that people are aware that they can, not that they can't, that they can.
And just to add a little bit to what Pat has said too, what we've seen here in Australia, particularly, that community and the community voice has had significant impact on changing how things are done. We referred, or we made comment before about accessibility, the building industries and so forth. There are now very specific codes here in Australia that any new development or remodeling or thereabouts must have accessibility requirements built in. If it doesn't hit there, it does not happen. So it's been the community base and the force of a community saying we need to make sure that we can adapt has seen significant change, particularly over the last few years in that area. And it's only because of the local and at the grassroots level that we've seen impact that is impacted right throughout the industry itself, to make sure that our disabled and others have the accessibility to wherever they need to go. And that will continually happen now in the way that it's structured here. Thank you.
Simran, let me just pick up on what Tony and Patricia are saying. I really love that angle of community, and I think there's a deep learnings there for especially people who are living in Kenya. But I want to take it further. I believe community is the picture made up of jigsaw puzzle pieces, that in that community there is the individual. And we need to get that individual to contribute to that community so that that community voice is an amplification of each one of our voices. So I really take that very to heart, what Patricia and Tony are saying about the community. And I want to take it further and say, let's build that community one person at a time. If we can get a critical mass of those individuals, and that's what then makes the community. Thank you.
Thank you. Mombi, do you have anything else to add?
No, just to say that based on what everybody has said, it's making sure that inclusion is not only my responsibility as the global head of inclusion, it's every single person's responsibility. And what I've seen to be really helpful is what I was saying, using the CRPD and also the United Nations Disability Inclusion Strategy, that has helped bring a lot of our colleagues together. So whether it's procurement, ensuring that what Tony was just saying, that the buildings are first of all accessible, the procurement that we are doing is accessible, just educating a whole group of people around disability inclusion, that has totally worked and will continue to be the vision where we'll see everybody included and no one is left behind, because that's one of our mottos. No one's left behind, and it's the same, I know, for this, for the symposium, for the summit. Really, those are the things that will make sure that everybody is included, and that we remove any barriers for people with disabilities and not see them as people who we have to do something for. It's removing the barrier so that everybody can participate at an equal playing field. Thank you.
Thank you. So if we were to summarize this and talk about healthcare, how would you complete the sentence and say healthcare becomes truly patient-centered care when? So in the context of people with disabilities and accessibility and moving from policy to practice, how would you complete this sentence?
Yeah, I'll throw my 10 cents worth in at this stage and say I think when you look at it, you start to look at the outcome from the patient's perspective. The fact that if we have achieved what we want, the patient doesn't have to ask for additional support or help. We've achieved it because we have been able to deliver for that individual person, whatever their disability may be. We have already looked at it and we've delivered it without them having to ask.
Just reflecting on what Tony is saying, I think that's really deep. If you focus on the outcomes, patients don't go to hospital to get treatment. They go to hospital to solve a problem. So treatment is the path of solving that problem. So if we focus on the outcomes and why is it that they've gone to hospital, I think we will be able to address what patient-centered care is. Reflecting on Tony, I think that's a really deep, very deep statement. And I think that really captures it very beautifully. Thank you.
So Simran, from an employee perspective, because for us, when you're thinking about my colleagues who might take care of with disabilities is not something we are going to treat, right? Respectfully to all the doctors, right? So there are some people who have permanent disabilities. So for us in the organization is using the human rights model for disability inclusion. And that means that we first don't see you as someone we don't see your disability first. We see you as a human being, and then as a person. And what we do is we understand what barriers are you facing to participate equally than other people who don't have a disability. And that's where then our reasonable accommodations process comes in. So we have a reasonable accommodation policy in the organization where anybody in the organization, whether you're a candidate, whether you're an employee or you recently have a disability, you can tap into the accommodation that you require to remove the barrier that you may be facing to participate equally. So if you're visually impaired, do we have screen readers for you? If at all you're autistic, we buy you noise cancelling headsets so that you can remove the barrier that we are facing. So for us is basically how we approach disability inclusion is beyond the label. So we don't see your disability. We first see you as a person who happens to have a disability. Thank you.
Matt.
And I'll go right back to what I was saying before. It's all about inclusivity, isn't it? Inclusive and exactly by what you were saying there, treat everybody as an individual, and then we look at the disability and see what we can do to help them. But we treat them as a person and as a personality. And I think that when you're working with, I've worked with a lot of people on the spectrum, and when you're working with them, they're all individuals and they're all different and they all have different needs. Some need the noise cancelling, some others don't need the noise cancelling. Some of them just want to play games on the computer, and that's okay as well. Others want to work, and that's okay as well. Let's find them a job. And one of the I don't know whether anyone knows what next weekend in Melbourne, in Australia, we've got 150 vision impaired and blind people going to drive a car around a raceway because we're giving them the ability to do that. And what they're saying to us is, we just want to be normal for one day. Let us drive a car. So they are going to drive a car around a raceway, and they are just so excited about it. But we've got to be able to treat people, you're right, as individuals, and that's what we have to do as a person. But yeah, we have to treat them right from home right through when they have to go into the hospital, if they need to go into hospital. Some people don't need to go into hospital. Some people don't need that, but they just need the care. And they just, and I will emphasise once again, I think we all have to look after the carers as well. And I think the carers are as important.
So Simran, I really love what's being discussed. Two things that come to me that I just want to ruminate what Mumbi and Patricia have said. Mumbi's approach, if we remove the barrier, so to speak, we actually then, you're not, for lack of better word, disabled anymore. So we bring you to that equity. I think that's very powerful. Patricia's comment made me reflect. There is actually a judge of the High Court in Kenya who's an avid golfer, and he's visually impaired. In fact, he's completely blind. He can't see at all. And he's actually one of the best judges, I dare say. And he's a very avid golfer and very, very good golfer at that. So it goes to show exactly what Patricia is saying. You do what you want to do and what you are able to do, rather than people telling you what you cannot do. I love that. Thank you.
You, Dr. Majid. Tony, Mumbi, anything that you'd like to add to that?
I think from the respect of the panel there has summed it up beautifully. We're talking respect, we're talking opportunity, and we're talking recognition and treating individuals as they are.
And just to add to what Patricia was saying, this is so important, especially when we are looking at the reasonable accommodation. Two of us could have the exact same disability, but we require totally different interventions. And that's why for us as an organization, we don't even prescribe anything. Even in terms of what disability is, we don't put a list of these are the disabilities that we're going to focus on. If you have any disabling factor, you come to us. You know exactly, the people who have disabilities know exactly what they need. So for me, it's just to enable that process to take place. You have this disability, this is what you need, you know it, and my work is to facilitate that, no questions asked, making sure that, we leave that really, the power is in your hands to tell us exactly what you need. And for us, it's to remove those barriers. So I was just reiterating what Patricia was saying earlier. Thank you.
Thank you. I think, do we have any questions from the audience, for if there's anything that the panel would like to answer?
Yeah, there are quite a number of questions. Thank you all. This has been really interesting, exciting. There's a question here from Sanem Nusrat. Well, that was a comment, but John says, my name is John, excellent panel. How far are disabilities in the Global South incorporated in the country's public health services? Neglected diseases causing disabilities are all in the Global South. Would like to take that?
That's a very deep question, because it's an intersection of multiple issues. Neglected tropical diseases, there's a reason why they're neglected, is because we don't think they make any money at all, if we're to be honest. So we need to, like any doctor, diagnosis before treatment. Then we add on top of that as a cause of disability, but also as a consequence of disability. So you can imagine a patient with leishmaniasis, or that causes severe disability, cutaneous leishmaniasis or visceral leishmaniasis. So you can begin to see that we need to also take responsible. I'm not a fan of taking the begging bowl to the Western world and looking for solutions when we can undertake solutions ourselves. If we can bring like-minded people, I may not have a solution, but myself seated with Simran and seated with Patricia, together we can come up with solution building on each other. So I think we need to look at those conditions like neglected tropical disease and ask who is neglecting them. And if we can answer that, then we'll see that, yes, other people can neglect them, but why are we also neglecting them? So then the responsibility is actually on us. Thank you.
Thank you. I've had the opportunity personally to interact with organizations that deal with neglected tropical diseases as a Rotarian, and we are working on a project around West Pokot, Ugandan border. So the way I look at it is that it's up to us, as you have said, Majid. If government is not doing it, I'm a Rotarian, I'm here, Simran is a Lion, she's there. So what are we going to do about it? Partner with the organizations that have already done the research. They have some of the solutions, or we come in and help them with the research, then come up with a solution, because it takes about 10 years to actually get something going around that. So, and I think when we say Global South, it's too broad. I find some of these things are based on a country by country situation. Some countries are advanced when they're dealing with some of these things. Other countries are still a bit backward. They're still dealing with issues of basic needs. So it's quite a broad question, but the challenge is to all of us to take it up. There's a question.
We need to go further. Sorry, just to add on that, we need to go further, because the whole concept of citizen scientist is now very, very prominent. Let's not be paternalistic either when we are dealing with this, especially with that intersectionality of disability and neglected tropical diseases. We need to involve the people themselves. Snake bites is considered a neglected tropical disease, but it's not everywhere. It's in a particular area. So you have different conditions at different areas. So if we involve the people there themselves in coming up with our solutions, the same way we are saying, let's involve the people with disability, and not just the people with disability, but the entire ecosystem. So similarly, let's involve everybody in the entire ecosystem in dealing with this. Thank you.
Thank you. There's a question here from somebody called Zoom user. So he says diagnosis is a big issue in our country. Is it medical ignorance? I'm not sure what country the Zoom user is from, but I don't know. Any one of you can answer on behalf of whichever country you imagine diagnosis is a big issue.
Let me start from Kenyan point of view. This is my personal belief that all our patients seek medical care very, very early. That sounds a bit contradictory to what has been published, but they get appropriate medical care very, very late. As a nephrologist, one of my biggest frustration was, I wish the patient had come to me 6 months earlier, we could have saved this patient. But guess what? The patient did go to a clinical person 6 months ago, but was referred to the right person very late. So when we're looking at it, it's not at the individual level. We need to look at the entire ecosystem of healthcare. And I believe the SDG 3 than universal healthcare, and focusing more on preventive and promotive rather than curative and rehabilitative would probably go a much longer way, and that would be a biggest bang for your buck, so to speak. So we need to look at it in totality as well. Thank you.
Another question from Zoom user. Policies never reach the lower income population. What do you have to say about that?
It's all about education and being once again talking about accessibility and people to be able to access that the medical care. I really don't know what the answer is there at all, but I think maybe we've got to have more accessibility for people so that they can understand what is available and where it is available. And I think one of the other things that one of my mantras is we have to give people up-to-date information as to what is happening. And I think I agree with you, Majid. You know, sometimes it's too late. People just can't get to care as quickly as they would like to. Sometimes it's because they haven't got the wherewithal to actually get to where they need to be. And I think that that's a real problem. And unless and until we can solve those issues, I don't know what more we can do.
There's another disease that I've come across, and both in medicine and in law, and this is a disease called poverty, which is very distressing because you know exactly what needs to be done, but the patient cannot afford to do it. I mean, very distressing. A patient had something very treatable, had straightforward malaria, but could only afford one dose of the medicine. Right. Now, what happens there? So it's a societal problem, and I think we need to be our brothers and sisters' keeper.
Yeah. There's no easy solution to that.
Also, ignorance sometimes, so that such that people go for like they go for late, what do you call it? By the time you're checked, it's a bit too late for you to get treatment, and you're just being one of those.
But you need to look at it broader. I give an example where a woman refuse to go for breast examination, even when she knew there was a lump in her breast, because she was worried if that lump is found that the husband will run away and will get married to somebody else. So unless you address those societal issues as well, so it's not as simple and straightforward. So we need to look at it holistically, that if we don't address this societal misguidance and how do I put it, dependencies. If that woman was financially dependent, it would not be worried about the husband running away. She would probably have sorted medical care much earlier. So for me, it's a lot of intersectionality. And as Patricia says, there's no easy solution to this, but we need to start picking at it and starting to break it down. Thank you.
Thank you, Majid. You just reminded me of a friend I lost about 2-3 years ago. She was diagnosed with breast cancer, but she didn't go for treatment because of religious concerns and restrictions. So she just braved through it painfully for maybe 4 or 5 years, and we watched her fade off, and she totally refused to go for treatment. So there are all those things coming up. There's a question here, a comment from Nusrat. She says, along community-based rehabilitation, implementing universal accessibility guidelines is critical for creating inclusive communities. I encourage Rotary to promote these standards across its projects and partnerships so that accessibility becomes a core principle rather than an afterthought. Really, really well said. Do you want to say something, Patricia?
No, I think it's all about accessibility, and I think that's exactly what we've been speaking about for the whole session, isn't it? You know, it's being able to access the care, and people. And once again, I'll go back to the carers. You know, it's the carers being able to bring the clients in or bring the patients in, or you know, it's really, really difficult for people to sometimes know where to go. You know, I think that this is all a part of education and awareness, and inclusivity and everything that we've been talking about today. And I think that I congratulate everybody. It's been a fantastic session.
So there's a comment here also from Naleni. As a disability researcher and activist in Canada, I was struck by an experience while visiting London. My 83-year-old aunt, a retired nurse, was told her home visit had been cancelled because no healthcare professional was available. The next appointment offered was July 29th, almost 1 month later. Inclusive healthcare is about more than policy. It requires timely care that preserves the dignity and well-being of older adults and others who depend on community support.
Absolutely. Absolutely, 100%. Absolutely, it's got to be able to help everybody, but how do we do that? Yeah.
So Ramu Kaladi says, being born in the Western world and living in the US, my whole life as a son of immigrants from the Eastern world, the Western world is not perfect. The Western world overgeneralizes the global South too much. How can we work together to help each other? Satoni, answer that.
Maybe that's Lions and Rotary working together.
And I think also having such such summits together and representing the world, then that will kind of bridge the gap.
Satoni?
It is, I think, the comment, it is working together where we have organisations such as, the United Nations, the World Framework, Lions, Rotary, who have a voice and have a, how could you call it, a collective bargaining power, if you like, because of the members' voices across the world, working together. And every country is going to be different in how it is looked at, and that's always going to be an issue. But as a group, having a formalised approach to look at the support, the mechanisms behind it, how we as an organisation can build the profile of what needs to be done for those in our community with disabilities, may be a way that we look at it in the future and use our influences from an organisational point of view to the other areas that need it. Government in many countries are the ones that provide the services. Do they provide the services that are really needed, or how about it? That may be a point that the voice of the community working together with others who are at the coalface of knowing what the needs are as we work together. Pat's right. We have a collective voice.
So John says, excellent answer, Dr. Twahi. Thank you. Faith, my name is Faith from Kenya, Nairobi. I'm a friend and an aspiring Rotarian at the Rotary Club of Westlands, Nairobi. I'm privileged to have attended this webinar. It's so insightful and informative. As a disability champion and advocate, I'm looking forward to learn more about disability inclusion, accessibility, mainstreaming, and advocacy. Thank you. Those are all the questions so far, unless there's anything more, Simran.
I think I just want to appreciate all my panelists and their expertise, and thank you for bringing out your various perspectives in your various countries. It's been quite insightful. I think I just want to also echo the thoughts of everyone that we need to come together as a larger community. Doesn't matter, shape, size, where we're from, never matters, honestly. And then champion that we advocate for policies to be put into practice, especially for these communities that also are part of us. So I don't think I have anything else to add. I just want to say thank you very much, Som, as well, for hosting us, and to the panelists for being part of such a huge discussion and this summit. It's been a pleasure.
Thank you.
Thank you very much.
Thank you.
Thank
Thank you.
Thank you.
Thank you, Simran. Thank you, our panelists, Tony, Patricia, Mumbi, and Dr. Majid, for a very, very enlightening discussion. We'll now take a short break and enjoy a special video segment called The Little Ladybug. which was created by one of the friends of the Rotary Club of World Disability Advocacy, Toon Sanders. He uses animations and creative media for educational advocacy and humanitarian outreach through the Hope Andishi Academy. This is a charming, short 3D animated film that explores the classic childhood themes of natural curiosity, consequences, and doing the right thing, and serves as an engaging way for children to learn important life lessons about obedience, responsibility, and making good choices. Please enjoy this video, and you can find many of his other amazing videos on YouTube. Thank you. Angie, over to you. Play the video.
Hello, little nature lovers. Do you know how maize grows big and tall? With sunshine, rain, and some tiny helpers too. These little heroes keep the plants nice and clean. Meet the ladybird, and let's enjoy the song together. A little red ladybird lived on a leaf. He lost one small leg, oh that was a grief. But the ladybird said, I will try my best. I may be different, but I'm like the rest. With 5 little legs, he walked very slow, up green leafy plants where the farmers grow. He saw tiny aphids, black and green. Munch, 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 I'll keep plants clean. In Africa, where the sunshine is bright, he helped the crops grow strong and ripe. The farmers smiled and said with cheer, this little helper is welcome here. So children, remember, big and small, different does not mean weak at all. You can help others, yes you can. Just do your best, that's the plan.
Sam, you're muted. Sam, you're muted.
Can you hear me now?
Yes, we can hear you.
All right, yeah. So I hope you've enjoyed that short video. I was hoping it would be longer, but it's been very educative. I love ladybugs. Explains why I love polka dots. After this short break, we move on to our second panel discussion, and I welcome everybody back. Our next session will remind us that truly inclusive healthcare cannot be designed for neurodiverse individuals without their active participation and leadership. Lived experiences, expertise, and healthcare systems become stronger when diverse voices help shape every decision. Moderating this discussion is Gaudence Ayoti from Tanzania. She is a distinguished social entrepreneur, tourism expert, and a passionate advocate for inclusive education. She's the co-founder and CEO of Dyslexia Tanzania, an organization dedicated to breaking stigma and creating equal learning opportunities for neurodivergent children across the country. With more than 2 decades of experience in the tourism industry, she's also the founder and CEO of Demi Tours and Travel Africa, using impact tourism as a vehicle for community development and social change. A champion for women's economic empowerment, Gaudence continues to mentor and inspire emerging African leaders. Please join me in warmly welcoming Gaudence Ayoti, who will introduce the panelists as we explore redesigning healthcare, centering neurodiverse voices in every decision. Welcome, Gaudence.
Thank you so much, Saum, for the warm welcome. It's a pleasure, and I'm quite honored to be part of this panel and also to be part of this Disability Summit, something that is very close to my heart. So this evening, we are going to have quite a dynamic panel of two panelists. And I would like to just mention their names. They're going to come and introduce themselves in detail. The first one is Amy Botkin from the USA. And Emmy is an autistic consultant. Emmy, you're welcome. I would like you to come on board and introduce yourself more.
Sorry. Thank you very much. I am autistic, ADHD, I have Ehlers-Danlos, I have POTS, I have mast cell, I have dyslexia, auditory processing disorder. I have a lot of letters after my name that I did not earn in school. And both of my children also have Ehlers-Danlos, which is a connective tissue disease. And we've spent a lot of time navigating the healthcare system. So this is a topic that is near and dear to my heart.
Thank you so much, Amy. You've been amazing. And just to say that we've worked together with Amy, she does sessions on my dyslexia online school. And it's a pleasure to work on this project together, Amy. Thank you for your time and for accepting to be part of this inclusion discussion. I'm going to welcome Wycliffe all the way from Nairobi. Wycliffe Owino is the Executive Director of NeuroBloom, Kenya, and he's a clinical officer. Wycliffe, would you like to tell us more about yourself?
Yeah, thank you so much. Good day and good evening, good morning, everyone. It is an honor. This is a genuine privilege to join you from Kenya and to be part of this important global conversation. To the organizers and to the Rotary, to the advocates, healthcare and researchers, and everyone and all the neurodivergent individuals joining us today, I want to say thank you for making space for this conversation. As you've been told, my name is Wycliffe Owino. I'm a clinical officer by profession, and I'm also a writer by passion and a grassroots advocate for calling. So yes, as you've been told, I'm the executive director of NeuroBloom Kenya. I founded NeuroBloom Kenya because I became convinced that healthcare should do more than conditions, and it should recognize the humanity of every person it serves. And over the years, I've had the privilege of working alongside families and listening to their stories and also witnessing both the strengths and the struggles they have to go through as neurodivergent individuals while they're navigating healthcare systems that were often not designed with them in mind. So those experiences have shaped my belief that the future of healthcare is not only about better medicine as we speak. So it's also about better relationship and better understanding and ensuring that every person is seen, heard, and valued. So I'm grateful to share this conversation with all of you today. Back to you.
Thank you, Wycliffe. And friends, I'm going to share a very personal experience. This year in April 2026, April, we had Dyslexia Tanzania. We organized a dyslexia awareness run in Dodoma. And during the promotion of this activity, we were in touch with a big referral hospital in Dodoma called Dodoma Referral Hospital. And we went there basically to seek support and ask them to provide us with an ambulance. And we told them we are doing a project that touches the community. It's about dyslexia. And amazingly, nobody knew about dyslexia, what it's all about. They called us for a workshop, and they put together all the doctors, and we had to speak about dyslexia, and they confessed that this thing is new. So when Rotary Club of World Disability Advocacy is organizing this kind of workshop, this kind of summit, talking about redesigning healthcare and centering neurodiverse voices in every decision. Imagine if medical professionals do not know about dyslexia. They do not know anything about it. How will a dyslexic person get help? How will an autistic person get help when they are sick? Because they also get sick just like anyone else. So this got me thinking about how much work we have to do to talk about how we should redesign healthcare systems to reflect, to involve neurodiverse voices so that they can actually get help when it's needed. So I'm going to read to you a small introduction, and it goes like this. Healthcare is fundamentally broken for those whose minds process the world differently. For decades, clinical systems have operated under a rigid medical model that treats neurodivergence such as autism, ADHD, and dyslexia as a problem to be cured or a behavior to be normalized. This panellistic approach creates staggering systemic barriers, turning routine medical care into an overwhelming, inaccessible minefield. True equity demands a radical paradigm shift. Redesigning healthcare requires moving past passive consultation and actively centering neurodiverse voices in every single decision. By honoring the lived experiences of neurodivergent individuals as the primary healthcare systems that bend to accommodate diverse minds, we transition healthcare from a place of forced compliance to a foundation of true human rights, accessibility, and dignity. So we are going to share an experience as a panel. And just to start us off, I'm going to ask our first question to Emmy. Emmy, could you kindly let us know what is neurodiversity and why are we talking about it at a health summit? At a health summit. Yes, Emmy, what is neurodiversity and why does it matter? Why are we talking about this at a health summit? Emmy, you're welcome.
Thank you. Neurodiversity, it basically means that your neurology seems to be different. My background is school psychology, and I had a specialty in neuropsychology. So those were things that I studied when I was in school. Our neurology develops over our lifespan. And when we are young, if something disrupts that development, then it's going to have an impact on what our neurology looks like. And so we see that a lot of times in what we call autism, ADHD, dyslexia. But the reality is that your brain is connected to the rest of your body. So if your brain develops differently than is expected, then there will be differences with your body, whether they are smaller differences or bigger differences. The majority of neurodiverse people have more health problems than the average person. And we have neurodiverse brains. Also, if somebody's not feeling well, they don't function well. Like, think of any time you've been sick and were you really performing at your best at that time? Probably not. And so a lot of times neurodiverse people will have health conditions, but they get ignored. I can think of a classic example from our own life. When my kids were little, they're both autistic. I took them to the doctor because something was wrong. Mom knew something was wrong. And the doctor said, they're just autistic. I wasn't happy with that. So I took them to a different doctor. And it turned out they had undiagnosed celiac disease. But because the doctor was looking at the fact that they were diagnosed with autism and that a lot of their behaviors could be chalked up to autism, he wasn't willing to consider that they might be hurting. And they were most certainly hurting, and their immune systems were not functioning properly because it had gone on for so long. We very often are not heard because our communication and behavior looks different from someone else's. And that is not an excuse not to listen to someone. We have to get better at communicating with each other. So that is a little bit about neurodiversity in healthcare. There are some significant some significant comorbidities for neurodiversity with healthcare. Some of them I mentioned earlier that I also personally have. I have a connective tissue disease called Ehlers-Danlos. If you have Ehlers-Danlos, you are 640% more likely to be autistic. And yet we do not screen autistic children for Ehlers-Danlos. I don't think anywhere in the world. I haven't heard of anyone doing that. I also have POTS, which is hugely comorbid with autism because it is disruption of the autonomic nervous system, that part of your nervous system that regulates heart rate, breathing, all those things you don't have to think about. Well, mine doesn't always work. And sometimes I will find myself suddenly very ill because my body is not regulating my heart rate, blood pressure, breathing, all of those things correctly. Mast cell's another common comorbidity where you develop very unusual allergies and sensitivities. And then on top of that, you've also got the sensory processing differences that can go along with how we perceive things. So someone might say, no, that's hurting me. You're like, well, it can't possibly be hurting you. It hasn't hurt any of my other patients. Well, maybe their sensory processing is different and they are feeling it. So there are many, many, many different ways that neurodiversity is something we've got to be talking about when it comes to healthcare. One of the most recent studies that came out said that in 51 different categories of care, neurodivergent people received less care than the typical person in 50 categories. So we are not getting the same care that other people are getting. And it is a serious problem, primarily because there was another study that was done a while back on autism. And the study found that the average lifespan for someone who is autistic is 36 years old. You might be wondering why that is, because you're like, I know plenty of autistic people that aren't 36. They're older than that. And I'm older than that. But the average lifespan is based on adding all people's lifespans together and then dividing by the total number of people. And so we've got some kids who die very young due to accidental death or due to lack of caregiver support. And then we've got other people who are at higher risk of suicide when they are in their teen years due to bullying. And then we've also got a higher rate of people as adults, if they make it to adulthood, with higher rates of autoimmune conditions and other kinds of chronic health issues. So it's extremely relevant. And there was also research a while back that was looking at the impact of trauma and anxiety on healthcare. And they found that depending on what they called an ACE score, that the higher your number was, the more significant your health problems were going to be, regardless of how healthy of a life you lived, because anxiety and trauma has a huge impact on our biology. And anxiety and trauma is something that goes part and parcel with neurodivergence, because it is not easy living in a world where your senses are telling you one thing and everyone else's senses are telling them something different. When people aren't listening to you because they don't believe you. Those kinds of things can be very traumatic, especially if that not being believed part influences your quality of care. I had a doctor one time not believe me that I had severe allergic reactions to things, and I was concerned about contrast in an MRI. She prescribed me Valium for anxiety. When I finally went in to get that scan done, the radiologist said, I'm not doing this until you're on steroids, because I am not going to be responsible if you have a reaction. And so we canceled it and had to reschedule because the doctor did not give me steroids the first time around. She did not hear my concerns. And so obviously these kinds of things can cause serious problems when people aren't listening. And to listen, it's not enough to open up your ears and hear the words coming out of people's mouths. To listen, you have to really hear their experiences and be willing to consider that they may have a different perspective and they may have different knowledge from you, and to recognize that their knowledge is not necessarily wrong. So that is why we're talking about neurodivergent healthcare, because it has such a huge impact on our health outcomes. Our health outcomes are not good. All of those studies I mentioned just now prove that it is not good. It is not good enough. So.
Thank you so much, Amy.
Can I add just a summary, something small on the definition of neurodiversity, how I understand it on the aspect of hospital and as a clinical officer. Imagine going to the hospital already frightened, and then only to discover that nobody actually believes what you're saying. Would you be back to that hospital? So it will be difficult. So in my thought, from a healthcare perspective, is that neurodiversity, it's not just about how people think or learn, but again, it also influences how people experience healthcare itself. For example, if someone is overwhelmed by sensory environments, then they communicate differently and has some difficulty expressing the pain they have. And that directly affects the diagnosis, the treatments, and even health outcomes. So that's why neurodiversity belongs at Health Summit today, in my own view. And it's about ensuring that healthcare works for every brain and not just the majority, where it was designed for neurotypical before, and the neurodiverse were not involved. So we are talking so that it involves everyone. That's what I wanted to add in the diagnosis, or rather the definition of neurodiversity.
Thank you, Wycliffe. And thank you so much, Amy, as well, for sharing your personal experience. You can imagine what you went through. You ran well, you're seeking help, and nobody understands you. Nobody is able to help you. And recently, I saw a post on social media that a place that should really humble you is a hospital. So you're going to a hospital when you need help and nobody's able to help you for whatever reason. So this brings us to the second question, and this goes to you, Wycliffe. If healthcare systems are truly being redesigned around neurodiverse voices, how do we ensure that neurodivergent individuals are not only consulted symbolically, but are actually involved in decision-making, policy design, and leadership within healthcare systems? Welcome, Wycliffe.
You're on mute.
Thank you for that question. I think, and I believe the question asks something much bigger than who sits at the decision-making table. It asks whether we truly believe that neurodivergent people are experts in their own lives. And for me, for a long time, I believe healthcare has been built with good intentions. The intentions were good, generally. Sorry, someone was calling and I'm using my phone. I'm sorry for that.
Okay.
So as I was explaining, that I believe the question you've asked me is that about who is making those decisions and is at the decision-making table. So, and we believe that neurodivergent people are experts on their own lives. So I wanted to say that for a long time, the healthcare has been built with good intentions. And quite often from the positions where professionals are, it held all the knowledges and the patients were expected simply to receive it, because the intentions were that when patients come into the hospital, they receive the best service, the best care. But the challenge is those who are making those models, neurodivergent people were never part of it. So the models which were made in the healthcare system did not fit the neurodivergent. So that model has achieved some remarkable things and a lot of remarkable things in other treatments, I believe. And we have a lot to celebrate the model, which was already there. So, but when it comes to neurodiversity, I think it has not achieved. It still has got some limitations, which we need to work on. So for in Kenya, I've learned that some of the most profound lessons about healthcare, they don't come from textbooks or lectures, right? And they have come from the sitting and the bedside. When you go to the hospitals, when you go to the bedside and listen to the patients, that is where you get the most profound lessons of how to treat a patient. So when you walk into that, when you sit with that patient, that is when you learn that this is how I should treat this patient. This is what this patient needs. And so spending more years on searching for answers for neurodivergent actually is not going to give us a solution if we still search for those answers without bringing them in and listening to them in their bedside and involving them in making those decisions. So I believe when they have to come from listening to the individuals, whether it's autistic, then they describe what it feels like to enter the hospital, where every light seems painful bright to them, and every sound feels overwhelming, and every interactions leaves them feeling misunderstood. So I believe that is what we actually need to understand first before, and we involve them before we do any other thing. That's when policies and decision making will really help the autistic individuals.
Thank you.
And the
Thank you
neurodivergent
so
as a
much,
whole.
Wycliffe. Thank you so much. We need to involve these people. As much as they're not professionals in the health system, they have lived experiences. So as you say, we need to involve them. And I love the point you gave that all the big lessons are not learned from textbooks only. You also get them as you practice your career. As you meet different people with different challenges at the hospital, you also get to learn more. So this brings us to the second question for Amy. Amy is a parent, Amy is an autistic adult, and Amy is a consultant now. But I know in your life, you have learned quite a bit about health. So we are going we would like to hear from you, Amy. What are some of the things we have what are some of the things from experience you know about neurodiverse health? What are some of the things you know about neurodiverse health? Amy?
One of the biggest problems we have, honestly, is inflammation. Inflammation is a huge issue within neurodiverse communities. Some of that I honestly think, based on the research, is because of the high levels of anxiety that we often feel trying to navigate a world that wasn't designed for us. There was a great little clip on social media a while back that showed what the world would be like if the world was designed for wheelchair users, and how it might be scary for someone who walks on their legs to be trying to navigate city streets where wheelchair users are zooming around at breaknecking speeds. And I think that's a really good visual image for how anxiety provoking and difficult it can be to navigate life when your brain is different from the average person's. And that high amount of anxiety, when we go into fight or flight, it causes us to dump all of our vitamins, minerals, neurotransmitters, hormones, pretty much everything your body needs to function, or at least a healthy immune system, goes into the bloodstream because it's a red alert situation. And then when we're done, then whatever's left is urinated out. The problem is that if you do this over and over and over and over again, you're going to deplete the very things your immune system needs to function. And so we end up with a lot of people who have a lot of inflammation, partly due to the anxiety that we could address better by making sure we're communicating more clearly and providing more options, perhaps even considering universal design within healthcare. So that's one area of concern. Another area of concern is that we've been saying for a while that autism is genetic. And we now know that if you have a connective tissue disease called Ehlers-Danlos that is genetic, that you are 640% more likely to be autistic. You're also more likely to be ADHD. I just don't have numbers for that one. So the odds of you being neurodivergent are extreme. One of the most recent research studies that's come out within the last year out of the UK was done by Dr. Jessica Eccles, and she was talking about how they have found that the left amygdala in the brain is enlarged with people with Ehlers-Danlos, and that means that that's going to have an impact on emotional regulation as well as executive functioning, and a lot of those things that we already see in those patients diagnosed with autism and ADHD. So a lot of times when we see neurodiversity, people look at it as a psychological diagnosis, and it is. But a psychological diagnosis very often is what we call something that is a physiological problem that we don't understand yet. There are things that we just don't understand about why people's brains work differently, but pretty much there's almost always a physiological root. I work with families all over the world, helping them try and figure out, okay, what does this child need to thrive? What are we missing? And the thing that I see with almost every single client, there may have been a couple that are just dyslexic with nothing else going on that did not show up this way, but even the dyslexic ones sometimes show up this way. Every single one of them shows signs of systemic inflammation. So systemic inflammation in children, some of the big things that I look for, copious amounts of earwax. Our ears make a lot more earwax when we have more inflammation. Another thing I look for is any kind of disruption in sleep, anxiety. That's how we're going to see it show up more behaviorally, because they don't feel good, so they're going to act a little differently. Another thing that we look for is constipation. A lot of times when we've got inflammation, there is some kind of difference with how the bowels are moving food through the system. And that's another big one. Let's see. Oh, also any kind of like eczema, itching, whether it's skin, hair, something like that. The skin is your largest organ, and a lot of neurodiverse kids have some kind of eczema that is inflammation. All of these things are inflammation, and very often when you get a neurodiverse kid, you're going to see signs of all of this in one kid. Also bleeding gums. That's another thing I look for too. Yes, sometimes if you aren't taking good care of your mouth, you might see some bleeding gums, but a lot of times it's a sign of inflammation. And if a child has multiple signs of this in multiple systems, it's not simply, well, you have an ear infection. This is something more systemic, because we're seeing this inflammation all over the body. And the sad thing is that most of the time people are so overwhelmed by the differences in behavior and communication that they never bother to ask or to look. And so nobody notices that the child has inflammation. Another concern is with Ehlers-Danlos, the connective tissue disease that I mentioned that we're learning so much more about these days. When you have Ehlers-Danlos, you have a significant amount of inflammation that gets trapped in the body. And I know a physical therapist who was able to do an autopsy on a woman who had Ehlers-Danlos. And he said that what was really striking to him when they did that autopsy was that as soon as they cut open the skin layer, the entire table was wet. And he said that was different from other autopsies he had done, because he said that with Ehlers-Danlos, so much inflammation is trapped between the skin that as soon as they opened up the skin, all of this inflammation was present under the skin. So there is a lot of inflammation that goes on with Ehlers-Danlos because Ehlers-Danlos is a connective tissue disease. Your entire body is made up of connective tissue. So basically what I'm telling you is that the connective tissue that makes up my body is made wrong. It's not made the way it's supposed to. And so it doesn't work the way it's supposed to. That means that I have symptoms in all kinds of different systems that would seem to not make sense to most people. Well, why would you have this problem with your knee and then you'd also have this other problem over here and then be allergic to things? It makes people look like they're crazy because people think, well, that's not possible. We actually have a child in our area that me and my daughter know, and she was recently taken away by the state because they believe that she was being abused because she couldn't possibly have Ehlers-Danlos. But she sees the same doctor that my kids do, and they are not being believed. And so her grandparents lost custody of her because of not being believed. This is a huge problem. One of my doctors, I told them, I have Ehlers-Danlos. She found out what doctor had mentioned that diagnosis to me and said that, no, you don't, because she didn't respect that doctor. So I had to pay lots of money out of pocket to go see another doctor to convince her that I had it because it was influencing my care. Another time I took my son to the orthopedist, and he was extremely rude to me for the only 15 minutes that I saw him, and accused me of trying to get my kids diagnosed with things they didn't have. And we had gone there to seek help. My son has pectus carinatum, where the chest grows outwards, and it may very well be linked to the Ehlers-Danlos. And I told him I was being treated and diagnosed with Ehlers-Danlos, and he's like, well, you don't want Ehlers-Danlos. I'm like, well, yeah, nobody wants it. On the bright side, I was able to advocate for myself, and I did not end up paying his bill because I told them I can get people to insult me for free. I don't really need to pay you to insult me for free. So that was nice, but there are a lot of people that really struggle to advocate for themselves within a healthcare system. I'll be honest, I am more fortunate than most because with my training and my background, I'm in a little bit better position to advocate for myself. But even I have tons of problems advocating for myself with my own doctors. If they don't know me well, I have a lot of trouble. I actually have a notebook that's this thick, and it's full of my medical records. And it goes with me to appointments because I have learned that if I go in and I try to explain to a doctor what's going on with me, they will not hear me, not the way I intend for them to. But if I go in with a notebook full of my records, all of a sudden people stop and pay attention because they realize that I've got something there. I've got data, I've got information, and I've got it pulled together and it's organized. And so that is one of the ways that I have managed to be able to advocate for myself. But Wycliffe mentioned the anxiety of trying to get healthcare earlier, and that is a huge issue. I've had cancer almost twice. We caught it right as it was becoming cancer the second time. And whenever I have cancer, I am not in a good place to advocate for myself. I am not capable. I am so anxious at that point because my first experience with cancer was rather traumatic. It was right after my daughter was born, so all my hormones were a complete wreck at the same time. And it was very difficult. And so anytime the word cancer comes up now with my health, I am not able to communicate as well. And I told my husband this last time, I said, look, the next time I have cancer, if I have cancer again, we are going to call a medical advocate, a patient advocate, because they can help you communicate with doctors. And that is one of the newest tools I've been hearing about here in the United States that I am really excited about. People that you can hire to help you navigate the healthcare system and to be your advocate. Sometimes there are times where we cannot communicate and advocate for ourselves because we are so overwhelmed. Not only with our own feelings and the fear that most people have about trying to approach medical care, but we also have the secondary challenge of trying to do that with a brain that functions very differently from the way the system is set up. So those are some of the common issues that we see with neurodiverse healthcare. There are a lot. A lot of neurodiverse people do have genetic differences that cause these things. If you have small genetic differences, it can have a huge impact on how you metabolize things and how your body functions at a cellular level. So all of those things can have a big impact. There are other ways that we have health issues, but I would say by and large, the biggest issue that we see is inflammation. And if you see a patient who is neurodiverse, the first thing you need to look for is inflammation, because I guarantee you, you're probably going to find it. So.
Thank you, Amy. You're like a library. You've got a lot of information. As you shared this, I was imagining now for a child who does not have a parent like you, what do they need to do? What do they go through?
It is so
It means their life
hard.
is very difficult.
Yes, it really
and
is.
At some point, you mentioned that you had to pay more money to get help, and it reminded me actually of a conference I attended. Dyslexia Rising Africa, and a parent said she has three autistic children, and everything all of a sudden is quite expensive. Even in the schools, she has to always pay more. And her conclusion of the matter got me thinking until now. She said, now the world thinks when you have special children, all of a sudden your income is multiplied by 3. You somehow have more money. You somehow have more money. Even the help you could get, even the house girl who can come and assist you always demands for more. Obviously, there's more work. So you reminded me this, and it's actually related to the question that I'm going to ask Wycliffe. Wycliffe, now your question reads like this. In many low-resource settings, like rural setup, healthcare systems are already overwhelmed. How do we redesign care in a way that remains inclusive for neurodivergent individuals without creating models that only work in wealthy countries or in urban centers where there's a bit more income? Wycliffe, will you take this one, please?
Yeah, thank you so much. So I want to start by saying that the most expensive thing in healthcare is not compassion, because compassion is always free. So when people think about redesigning healthcare, they often imagine expensive buildings, special clinics, advanced technology, and those valuable, but they do not, those are the not only things to improve in care for neurodiverse. So in many rural settings, if I can say, we may not need to have immediate access to very high special care because they are already not there and they are very expensive to bring. And if we say we want them right now, that is a lie. It's not going to happen. But again, if we have a progressive way of saying that we need this, then it will happen. So where do we start from? So we can start building healthcare that is respectful and inclusive, in my own view, that even if we don't have the resources, even if we don't have everything, but compassion is free. We can start from there. Even if we don't have everything in rural setup where people don't have information, stigma is real, then why don't we start by improving the communication? So that why don't we start by training frontline healthcare workers to recognize those neurodevelopmental diseases in the rural setup? We can also improve that in our communications with the families in a way that we understand, where we don't stigmatize them, we don't label them. So we can reduce the unnecessary sensory stress where possible. Again, we can involve community health workers to identify and support those children early, something which does not require a lot of money and resources to start. So another thing I think we can do, and maybe Rotary and other organizations and the partners can come in, is we can find a way of partnering with schools and the community organizations, the rural setups, so that we support neurodiversity. So those changes, they always do not require a bigger budget in my own view, but they require some commitment, and that we need to see every person as worthy and compassionate for care when it comes to rural. So innovation should not be measured only by how much money we spend or much money a country is wealthy, but it should be also measured on, by how we listen, adapt, and even respond to people's needs, because that is the major challenge. People are labeled, neurodivergents are labeled at the community and at the rural setups. Also, I think if we can have an inclusive healthcare, which should never have a privilege available for any wealthy countries, to me. That's how I see it. So, and most important thing is compassion, which is very free. That's all I wanted to say. But again, people will come by asking, I saw someone asking a question somewhere and I wrote it down, that, so does acceptance means giving up? If those in the rural setup, then they accept, yes, they don't have the resources, but they have accepted. Does it mean giving up? To me, I think it is not so, because people communicate, learn, and reduce pain and improve mental health and live independently where possible. So acceptance is not the opportunity of growth, but acceptance means growth begins with dignity instead of shame. And if we give them that at the rural setup, where we give them the dignity and there is no shame, then it starts from there without even much resources. That is what I can advocate for today on that question you've asked. Thank you.
I'd like to jump on real quick on that and say that we've talked before, and it is so true. Our environments may look very different, but we still have the same basic problems. It is a need for compassion. And even if the way our healthcare looks or the way our lives look, even if those things are different, we still struggle with a lot of the same things. I know so many families in the US that are in financial debt trying to afford basic care for their children. It is a problem worldwide for families that have kids with some kind of a disability, whether it's neurodivergence, whatever it is. The problem is that anytime you serve a special population, it seems the price tag goes up at least 300%. And turns out the family's incomes are not going up 300%. So the problem is real and it is everywhere. It just looks a little bit different depending on where you are.
Thank you, Amy. And I like the fact that I have you from the US and I have Wycliffe from Kenya. So we have both sides represented. And guess what? Wycliffe, you just don't know. You just mentioned something that I never thought of. And it's actually, so when we are thinking of redesigning healthcare, we are mostly thinking, how will I change this whole facility? Yet it can be as cheap as just me changing my attitude. It can be as expensive as me trying to be compassionate. And by the way, Wycliffe, another point that you've left me thinking about is, not everything has to cost money. Like I run dyslexia online school. Amy here has volunteered twice. A whole hour, she has shared her knowledge on my platform, and so many people have already learned about neurodivergence. So, and I didn't pay a single cent. I just asked Amy, could you volunteer? And she's facilitated twice. So it's not always everything that will cost us money. We can be compassionate. We can reduce the stigma and look at them as just like anybody else trying to navigate this world, So thank you so much, Wycliffe. And Amy, thank you for the additional, that compassion actually, it cuts across.
Yes.
It can apply in rural setup, it can apply in Rwanda, in Kenya, it can apply in the US.
And that compassion, that is why I work with parents now. I used to work in schools, but I realized that if you really want to make a difference for a child, support their parents. Because no one has a bigger impact on a child than their parents. And their parents may not have a lot of money to work with. They may not have a lot of resources. They may not have a lot of knowledge, but they've got a lot of heart. And if we can support them with that heart and get creative, okay, what do we have to work with? What could we do? What could we do to make things just a little bit better? Then that makes a huge difference. And it doesn't take, years of interest groups and committees and lots and lots of money to make a huge change.
Yeah.
Wow. Thank you, Amy, for that additional.
Supporting neurodiversity does not mean that those struggles don't exist. Yeah. They exist. So we are just acknowledging that the struggles are there and those struggles exist. And that's why we are going to be compassionate as we handle everything. Yeah.
Thank you. Thank you, Wycliffe. And actually, as we talk about collaborating, recently I got a project. We have discovered that people who use sign language, some children who have autism, they do not have speech. They're nonverbal. And the doctors, the healthcare professionals, they do not know sign language. So we are working on a project actually where we can train healthcare professionals on sign language, at least basic sign language, so that when a nonverbal person goes to see a doctor, they have some privacy. They can see a doctor and the doctor can at least understand some of the concerns without involving a third party. So indeed, and we can collaborate, and this can be a collaboration between schools, hospitals, it can be between non-government organizations like what we are doing at Dyslexia Tanzania to collaborate with the hospitals, with the government. We are actually now working on an MOU with the government to see how we can support each other. So thank you so much, Wycliffe. That question is quite well tackled. Let me now pick your minds. Amy, we are having this question. I would like you to answer. If medical professionals want to help neurodivergent people live with neurodiversity well, what can they do? Let me repeat again, Amy. If medical professionals want to help neurodivergent people live with neurodiversity well, what can they do? Welcome, Amy.
Thank you. The first thing that they can do is it comes down to changing your attitude. Just what Wycliffe was talking about, deepening a sense of compassion, but also being aware of our own biases. Being aware that just because someone comes off as sounding like they're crazy doesn't mean they're crazy. It could be that they have a health problem and they need help. And also, I would say get creative in how you can provide that care. One of the things that has been a wonderful asset to us since COVID is that now our doctor will do remote calls with us, which is wonderful because our doctor is two towns over. So it's a bit of a drive to get there. And also, being in a doctor's waiting room sometimes can be very overwhelming because it's either too hot, it's too cold, there's too many people, it's too much noise, you're sitting still too long. Like there's all of these sensory issues that are difficult to accommodate for. And a very easy way of accommodating is to be able to provide remote communication. You know, there's a lot of technology out there. I know a lot of my doctors are starting to use AI to take notes in my appointments, which I don't mind because quite honestly, I think that they sometimes probably take better notes than the doctors do when they're trying to talk to me at the same time. I can't take notes and talk at the same time. So I don't see how they could do it. But, you know, we could also get creative with how we are using these new technologies. Maybe we could, you know, have somebody who is in charge of communication with patients via text and use AI to help us. How can I say this in a way that will be understood by this person? Sometimes that could help us. And these are things that are readily available online for free. Things to help us improve our bedside care. We've got to start from the idea that the child and the parents and the adults are not crazy. That is not where we start. If you are in medicine, that is not your lane. That is the psychologist's lane. And if you think it's a concern, then you should refer out. But if someone comes to you and says, I feel bad, I need help, assume that they need help. I can't tell you how many children I have worked with who have been told, oh no, you don't have seizures. You have a neurological function disorder that keeps you from, it makes you think you're having seizures. And the child actually has a connective tissue disease that is comorbid with seizures a lot of times. I've seen this so many times. It is ridiculous. It's really, honestly, it's sad because so many kids do not get the care that they should. I have seen kids go from being relatively healthy looking kids that are walking to not being able to sit up on their own anymore because of the health care they received, because it was inappropriate. And some of this isn't just the medical profession. Some of this falls on the parents and the adults as well. We can do things to improve our own access to medical care. Like I said, one simple thing I did was just collect a notebook and organize it of my medical records. And because I'm not coming in with a folder full of messy papers and I'm coming in with a notebook that's organized, people go, oh, she knows what she's talking about. That makes a big difference. And that's something that I could have gotten help with from someone. I did it for my children. They each have their own notebook now that has all of their records in it, so that way they have a tool when they go into a doctor. We can also take a friend. I took a friend with me this last time when they thought I had breast cancer, and I didn't. They thought it 5 times, and they couldn't believe I didn't, because my body does weird stuff, and so it looks like one thing, and it never turns out to be the one thing they think it is. But she went in with me and worked to try and help communicate for me what was bothering me. And she was helpful. She was with me when the radiologist agreed not to do the MRI until I was on steroids. So that's another tool that can be used in our favor. But I would say, honestly, as far as the medical profession goes, the biggest thing is to listen and to recognize your patient as an equal partner. You don't know how their body feels. They do. Nobody knows their body like they do because they live in it every single day. Yeah. And so if you can really see them and remember, this person is my partner, and they have things that they see that I'm not seeing. They have a piece to contribute, and respect that, and to have compassion for, you know what, they have something to contribute. They seem really anxious right now, but they still have something to contribute. How can I relieve that anxiety? What can I do to put them at ease? One thing that you could do is when you're doing intake paperwork, I mean, there is a ton of questions that are asked in intake paperwork that I fill out. I can't tell you how many hundreds of pages I have filled out in the last 3 years. Include some questions about your preferences and communication and sensory processing. What kinds of things cause you more anxiety? What kinds of things are helpful when you're anxious to relieve anxiety? Collecting a little extra information on the front end might make a huge difference. You know, how do you learn best? Is it best if it's written out for you? Is it best if, you know, I give you an example? You know, those kinds of things can be very useful. And then also, I think really honestly, if you're going to look at it, it really all does come back to compassion. I think a lot of doctors are under a lot of stress. They have a lot of systems that they have to answer to. There's a lot of pressure. And then on top of that, they're also dealing with people who are not at their best because they don't feel good. And so they are under a lot of pressure. And I know in the United States, we've got a lot of doctors under pressure because our insurance companies are kind of driving care now and telling doctors what they can and can't do, and telling them you can only spend 15 minutes with a patient, which is just not enough if you have a patient that's neurodiverse. So I think that, you know, there is definitely an amount of pressure there, and I want to acknowledge that. But I think that we can still get creative. You know, maybe your office hires somebody, because maybe you're in the United States and you only get 15 minutes per a patient. Maybe you train and hire somebody who is not, you know, medical and doesn't require as large of a paycheck, maybe, to just get to know the patient for a few minutes before you get in there and try to put them at ease. Somebody who's a good people person, has good natural people skills. They could collect some information for you on the front end. You know, a lot of times we will see, in the United States, I'll see nurses come into the room who will come and collect information. But, you know, again, that's somebody that you have to pay a decent amount of money because they have certain degrees and certifications. And they're also looking at it more from a medical model. I know there's some doctor's offices, my kids went to one, they had a therapy dog, which was kind of neat. They went above and beyond to try to find ways to make you comfortable. So if I was to sum it up in 2 words, I would say compassion and, well, I'm not sure if I can put this one in one word or not, but believe your patients. They are not necessarily crazy. That is not the assumption. They are probably highly intelligent.
Thank you so much, Amy. You're just amazing, you know. And you reminded me that, you know, when you were looking for one word you can sum it up, instead of saying believe in your parents and your patients, I thought of maybe take your patients as strategic partners, trying to sort out something together. They have a point to put on the table. They live in that body for as long as you can imagine.
You're
so
right.
Thank you so much.
You're right. And you know what? when I work with parents, I tell people all the time, a lot of the parents that come to me, they say they've been to professionals where professionals basically think they're crazy. And whenever I get a parent, pretty much every single time, parents have knowledge. They know something. They might not have the right words to explain it. They might be attributing it to the wrong thing, but they know something.
That's right.
It is on me to try to figure out how to listen to that parent and figure out what knowledge they have to share with me, to partner with me to help their child have better long-term outcomes.
Thank you.
Right.
Thank you so much, Amy. You've answered it quite well. I'm sure you're emptying the questions for the audience, and we have quite a few minutes to go. We have very few minutes to go. So, and this has been quite an amazing session, Amy. You've answered it quite well. You've even added things that the patient should do. The question was, what can the health professionals do? You've added what a patient should do. Patients also need to know what they're suffering from. Like, I love and I admire the fact that you have all your medical records together. So quickly, we have our last question for Wycliffe. Wycliffe, try to be a bit fast because our time is running out. So this last one is, it says, trust is central to healthcare outcomes. For neurodivergent individuals who have experienced misunderstanding, stigma, sensory overwhelm, or dismissal within medical spaces, what practical changes must healthcare systems make immediately to become truly safe and accessible environments? A quick one, Wycliffe.
Yeah, thank you so much. Number one, I believe trust is one of the most important medicine in healthcare, because you develop trust one-on-one with the patient before you do anything. And again, listening before making a diagnosis, because patients are not diagnoses. Diagnoses are labels, in my own view. So for you to make that trust, the patient need to understand and living beyond diagnosis, and living beyond autism. Yes, I have autism, but how do I live with autism? That is where we have dyslexia, yeah? But how do I live with dyslexia? So it's living beyond diagnosis, living beyond the label itself, that yes, this has just helped me to understand what I have. Now, how do I live? So that comes from trust. So when someone repeatedly feel dismissed in a way in an hospital, or misunderstood or judged, then they just avoid the hospital. Just as I said before, they will avoid that hospital, and that effect will not only affect their health, but also their confidence in the whole system. So for me, I will say that let's begin by trust, and that will give us some actions to do. How do we bring that trust? It means listening without assuming these people. Let's listen to every patient. When you walk into the hospital, or when you're in the hospital, you're sitting there as a clinician, as a nurse, as a doctor, then don't assume them. It also means asking. How can that be of best support today? Can we be of best support to you? So you ask them, you ask the patient, you ask the neurodivergent, you ask whoever you're seeing the question how you can be of help. Then it also means you respect their communication style. Some are slow to speech, some are nonverbal, but that is their way of communication. So you have to respect every person's communication style. And it also means explaining all the procedures clearly. This is what we're going to do. This here and here and here, these are the procedures we are going to do. So at least they get to understand that, and the caregiver also understand that, okay, this is what we do, after this is what we do. So it's clear, a clear procedure for every person that will build the trust. And it also means recognizing the sensory environments, which affects ability of every person's care, especially in neurodivergent field. We have to recognize that sensory environment. It's very important for any neurodivergent individual. So most important, it means seeing the person before diagnosis, as I said before. And trust is not only built through the policies we were speaking before again. It is only alone that the policies can bring us there. So it is also built from the conversation of time to time, that one-on-one conversation. Yes, we have good policies. We were advocating for good policies. Fine, we have them right now. But does that alone help? Does that stop misjudgment? Does that stop stigma? No, it doesn't. So we also build the trust from one-to-one conversation in a way that it is respectful and it's an interaction at that particular time. And it's show respect to that particular individual you are seeing at that particular moment. So neurodivergent people feel genuinely seen at that time and heard and valued, just like any other person. So dignity again becomes becomes not only more accessible but also more effective for any other person. And we bring what is called patient-centered care, which was the previous session before we joined. So it is a patient-centered care which brings the trust. So that dignity is not only efficiency, and it becomes something, again, it will fall under compassionate again. You will have again to be more compassionate. So I would say that let the future generations, when the future generations look at us, they don't come in and say and remember us by saying, oh, we built good policies, we built good hospitals, smart hospitals alone. That is not going to be enough. But let them also see us as the generations that finally led them to see every person, led them to see every person with dignity, with hope, not as a diagnosis, and not as a burden to any other person. And again, not as a problem to be solved or to be fixed. Because neurodivergent are always seen as a problem to be solved or rather to be fixed, or as a disability as a whole. People feel like, this is a problem to be solved or to be fixed. So let the generations which are coming to see this differently, but more importantly, to see them as human whose life has equal value in the community. That is what I have to say.
Thank you so much, Wycliffe. And you sounded like you're giving the conclusion of the discussion, and this is actually it. It brings us to the end of our panel discussion. But I'm going to read to you a small conclusion here because time is not on our side. We don't want to take time for the next panel, for the next session. So this is the conclusion of the discussion we've had so far. Redesigning healthcare is not a matter of charity or checking an accessibility box. It is a fundamental shift in human rights and systemic equity. The only way to truly achieve this redesign is to center on neurodiverse voices in every single decision. Tearing down a rigid one-size-fits-all model and building a healthcare system that is flexible enough to welcome every mind. The core shift is here. This approach heavily embraces the social model of disability, which suggests that a person is not disabled by their medical impairment alone, but rather by a society that fails to accommodate their differences. Health is the ultimate foundation of human potential, which explains why it sits firmly at the bottom of Maslow's hierarchy of needs as a critical physiological requirement. A person cannot learn, work, or thrive if their basic well-being is compromised. I want to thank you so much, Wycliffe, for the amazing session we've had. Thank you so much, Amy. And a big thank you to Rotary Club of World Disability Advocacy for creating this platform that we can share with the whole world about how we can center on neurodiverse voices, even in the space of health. Thank you so much, everyone. And over to the hosts. We have spent our time very well, and I'm proud of my panelists. Thank you again.
Thank you, Gaudence, Amy, and Wycliffe. I felt like I was in a masterclass, but people with lived experiences, so it's totally different. It didn't sound theoretical. Everything you said and shared and explored were very practical, and I really, really appreciate that kind of knowledge. Just a few comments from the chat. Hi, my name is Lucy Karabo, founder of Girls Lifeline Organization from Uganda. Humbled to be here. She's shared her number and her organization in case anybody wants to get in touch. I hope you all know our email address, the same one that you registered with. You'll find our website there. So in case you want to get in touch, just send us an email. Monica says, my name is Monica Raheru. I'm a stroke survivor from Uganda. Please handle something on panic attack following sleep paralysis episode. Could it be sleep posture? How much is enough sleep for neurodivergent persons? I'm also the director of the Champion Root Foundation, where we foster rural children with neurological disorders, where we are geared to eliminate the misconceptions about disability, especially neurodivergent cases. And she has shared her email address. Paris Wangare. Hello, amazing conversations here. I'm really happy I joined in. I'm Paris from Kenya, Nakuru City, founder and CEO of a lived experience-led organization known as Arthur for Others, which works with neurodiverse persons and their families. Hi, Amy. Great to see you from Emily. Phoebe, a beautiful presentation. Thank you all for the insightful data. I don't know if I've left anybody else, but so far those are the comments. And there was that one question from Monica. But otherwise, really, really amazing panel discussion. You kept time. Thank you for observing time. Unless there's something burning, I would like to move on to the next session, which is another exciting panel discussion, our third panel discussion for today. For many people living with disabilities, pain management is deeply personal and requires approaches that respect individual needs, preferences, and experiences.
You're frozen, Sam?
Yeah, I think she's frozen.
Okay. I can take over until she comes back. So we're going to bring all... Okay, yay. Okay, it's all yours.
Yeah, so we had this blackout, which was not foreseen as usual, and it takes time to get the backup up. But yeah, so our next session, which is our third for today, is on pain management being handled by, just give me a minute. Can you hear me? I feel like I'm losing out.
Yes.
Yeah, we can hear you. Yeah.
Yes.
Okay.
You still there, Sam?
Yes, I'm here. Sorry.
Oh, okay. Okay, so we're fine. Well, Sonia's up, the moderator, so we can start that way.
Yeah, we can start immediately. So we have Sonia, who's our moderator for today. Sonia is from Kenya, and she's a member of this club. She's very passionate about education, special education. She's a special education needs advocate and a community leader dedicated to advancing inclusive education and empowering young people. She serves as an educational consultant for the East African Ramgarria Board, where she develops youth programs, supports community schools, and promotes social impact initiatives. As the secretary of this club, Sonia is a strong champion for the rights, inclusion, and integration of individuals with diverse learning needs. Through her leadership and community engagement, she continues to inspire positive change and foster more inclusive societies. Please join me in warmly welcoming Sonia, who will introduce our panelists for today's sessions. Welcome, Sonia.
Thank you, Sam. Thank you so much for that introduction. Good morning, good afternoon, good evening, everyone, wherever you are on this beautiful panel that we call home. So here we are talking about the rise of alternative medicine, patient-centered care that transforms pain management. I do understand from the marketing team that this particular session has created a lot of excitement. Some were flabbergasted as well, I believe. And a lot of the response that we received was that they were a bit surprised that we would be talking about this session as well. So let's start by reminding us that the hardest part of advocacy indeed is talking about the real challenges that we face. People with disabilities have so many challenges that they have to live with, some from birth, maybe even during conception. Perhaps one of our panelists will correct me if I'm wrong, because that is exactly what he does. Maybe after an incident, an accident. But when we look at holistic health, we have to understand that there's more to who we are in terms of our physical health, our mental health, our emotional health, and above all, our spiritual health. So before I introduce my wonderful, wonderful panel, which was curated and is joining us from Kenya, mainly. 2 of our panelists are from Kenya, 2 are from the USA. We're going to see how both these countries look at holistic approach. But before that, there's so much that we have been listening to, learning, and engaging with. So let's take a breather to live in the moment and appreciate our own life journeys in this safe space of acceptance and unity in advocacy. I would like to request the technical team to please put up our special meditation video before we start our session. Thank you. So you will see before you the image of the triangle. Music provides us. We breathe in, we hold, and let's just breathe, giving, live in this moment. Breathe in, hold, and breathe out. Breathe in. Technical team, thank you for support. So I hope that helped you to rejuvenate just the way it helped us. You can see my panelists are smiling, and so am I. And that is the power of conscious breathing. The first step towards self-healing, self-advocacy is when we take care of ourselves and our health. So allow me to introduce my panel now. As I said, the panel represents voices from both America and Kenya. Although our countries differ in their healthcare systems, legalities, insurance coverage, and cultural beliefs, we are witnessing a common global trend. More and more patients are seeking holistic approaches to health and rediscovering forms of ancient wisdom that have been supporting communities for generations. I would also like to remind our viewers that this panel is here to share their knowledge based on their expertise. This is for us to share our love, our care, and the divine blessings that we have received. We are sharing this with the world as a gift. So please do receive it as a gift. Thank you. So I would like to begin by introducing my panel. I'm sure you're very excited, just as I am. So in no particular order, allow me to introduce to you the first person that I am seeing on my screen, which is Dr. Glenn Mendoza from the United States of America. He is a highly accomplished neonatologist and associate clinical professor with 30 years of experience directing the NICU at Good Samaritan Hospital and managing early intervention programs for children with disabilities. Alongside his medical career, he is one of the only 8 master pranic healers, which is energy healing, globally, leading organizational development and outreach for the energy healing modality. Recognized as a top medical doctor in New York for over a decade. In fact, he's been in it for more than 20 years, is what he had mentioned when we had our initial discussion. He continues to expand his professional credibility and network into new domains. It is so much he's doing. He just mentioned there's something that he's also doing for cancer patients, and he's charting new pathways through his work. So thank you, Dr. Mendoza. Thank you so much for joining us today. Thank you. Next, I would like to introduce Dr. Dinesh Varsani, who is based in Nairobi, Kenya. He is a practitioner who provides natural wellness support through traditional Ayurvedic therapies, holistic bodywork, and naturopathy. His vocation encompasses offering specialized services, and I hope I'm going to say this right, like the Shirodhara, acupuncture, acupressure, and custom wellness packages alongside curated herbal product guidance for many ailments often related to pain issues and management. One of our youngest panelists next is Neil Dodia, and I will say it in the same breath. He's also from Kenya. So as I welcome Dr. Dinesh, karibu sana, Neil as well. He is, as young as he is, he's an established alternative wellness practitioner and a pioneer in sound therapy within Kenya, offering over 20 years of experience in holistic healing. His clinical practice integrates a diverse range of specialized modalities, including Reiki, Tibetan Bow and Gong resonance therapy, crystal reflexology, therapeutic bodywork, and trauma-informed emotional release. Utilizing an intuitive client-centered approach rooted in traditional wellness practices, Mr. Dodia specializes in facilitating deep restorative care, stress mitigation, and comprehensive emotional and physical ailment. Welcome. Last but not least, thank you. I know we always start with the ladies. but I wanted to give a special introduction to Dr. Melanie Joy, who is a board-certified holistic clinician with over a decade of experience in functional nutrition and integrative health, living in Pensacola, Florida, USA. Through her private practice, she uses a personalized root cause approach to support both the physical and emotional well-being of her clients. So welcome, and thank you so much once again for accepting our invitation. Thank you. I want to jump right into the questions because I know my panel is ready. So I would like to begin with a question for each one of you. And the question is that from your perspective, what does healing truly mean, especially for persons living with disabilities or chronic pain? May I ask Dr. Dinesh Varsani to please go first? Thank you.
Thank you so much for giving us a golden opportunity to share our experiences and views on this. Well, the difference between healing and cure. Now, as far as the disability is concerned, the chronic pain through lifestyle and life awareness is basically better to look into it. Whereas Ayurveda, the science of an ancient Indian philosophy, Ayu means the entire lifespan, right, from conception to death, and Ved means knowledge about it. So Ayurveda basically tackles the entire lifespan of a human being, where Ayurveda firmly believes that a human body is made up of 5 universal elements: earth, water, air, fire, and space. The combination and permutations of those 5 elements results into 3 constitutional energy, which is known as Vata, Pitta, and Kapha. Now, Ayurveda, as far as health and healing is concerned, it believes that a human body's health is not achieved only by physical health. It is mental, physical, emotional well-being, whereas Ayurveda believes that your physical body health is basically determined by proper secretions of your stool, urine, sweat, and balances of all the 3 doshas. That is Vata, Pitta, and Kapha, which are those 3 constitutional energies which determines a human body as a whole. So where the healing and cure comes in a disability, it's very difficult because the disability is basically a permanent condition, where what we can do as Ayurveda is concerned is try to balance the doshas. Suppose if there is too much of pain, that means there is aggravated Vata, there is excess Vata. So that is causing either obstruction, dryness within the system. So you look at how to specify Vata, how to reduce Vata so that there is less pain, there is less stiffness, there is less wear and tear in that area. So how you can achieve that is by applying little bit of warm oil, gentle application. Because in disability cases, most of the time over my 30 years of practice in this field, we have seen that where there is a disability, there is a lot of inflammation due to wear and tear. And what happens when there is an inflammation, you do hard massages or deep tissue massages, you create more damage and more pain. So what Ayurveda suggests is gentle warm application specifies Vata, so the stiffness and pain reduces. Mainly the best oil recommended by Ayurveda for Vata specification is Simsim oil. But you can also use coconut oil, mustard oil, even castor oil, which also gives fantastic results in inflammation. So this is one way. The other way is dietary regime. If you follow the diet, what a Vata specifying diet, mainly warm and lubricating diets, which reduces Vata. Then your dincharya means your daily routine, sleeping on time, waking up on time, eating on time. These are things which you need to observe properly so that the three constitutional energies are well balanced and they function properly. So basically, people with this disability, what I have seen, because I am one of a parent with a special child. My son is already 26 years old. He was born with the hearing disability. And the earlier panel, what I was listening to, well, I've gone through all that, what they have discussed. So basically, one has to, as a practitioner or as a caregiver, when you're taking care of disabled patient, you need to look at their mental, emotional well-being. You have to find out purpose and quality of life. You see, I always believe that disability is not an inability.
True.
You can always achieve a meaningful purpose of life. So by what happens is Ayurveda helps to achieve self-confidence by reducing Vata or balancing all the three constitutional energy. So mental health is also achieved through balancing the doshas. Basically, when the Vata is excess, what happens? Person becomes restless, forgetfulness, and all that. So Ayurveda basically believes that one should not limit its physical status. You can rise above that physical limitations, and you can grow in your day-to-day life, and you can do a lot for the society.
Thank you. Thank you. Thank you for even clarifying that you're talking about the physical disabilities. It is good to specify. So thank you so much. And thank you for advocating for your child as well. Thank you, Dr. Dinesh. Dr. Mendoza, I'm sure you have a very different approach to that. So please do share your views on that as well.
I think I'll describe it into two ways. As a medical doctor, I think medicine looks at health as actually a state of well-being. It's a state of well-being, not only of the body, but of the mind. So that is actually health. Or if you have to add, I think one of the description of health is absence of disease. So this is where our disability, our understanding of disability. Now, I am also, as Sonia mentioned, thank you very much, Sonia, that I am also a practitioner and a teacher of energy. So as far as energy is concerned, it's related to health. If I cannot move my arm, that means energy is not flowing. But if energy is flowing, I could have movement of my arms. If my relationship is not good, energy is not flowing. So if society is deteriorating, energy is not flowing. So from an energy point of view, energy has to flow. In health, energy has to flow. Thank you.
Interesting. Thank you. So when I look at both Dr. and yours, when he's talking of Vata, that Vata, I believe, is the air aspect of the body. That in itself explains also the energy aspect and how it's all integrated. So thank you so much for that, both Dr. Dinesh and Dr. Glenn. Thank you so much. Neil, what do you think? What's your
my as Dr. said, the energy. So I believe in in energy as well. And one of my biggest practices is involving energy and the mental wellness, because energy, when energy is dealt, when you deal with energy blocks, when we deal with that, and we deal with the physicality and the mental wellness, it's all integrated. So when you're working with energy work and you start receiving and blocking the energy blockages, your physicality starts changing and transforming. When this transforms, your mental wellness even, because energies take care of the mental, physical, and emotional side. So all these three aspects is taken care of. And when disability comes, when I understand, there's a lot of stigma, there's a lot of, how do I call it, mental, physical, and emotional blocks that create. When we deal with it in the energy way, it really helps open up the person, gives them confidence, gives them the boost, and helps the disability to become not a disability, but an ability to fight the outer world. So I start like when a person with disability comes in, you really have to mentally even give them the courage and confidence to help them fight the outer challenges of the world, because that is one of the things you really mentally even have to, give them a boost. And with emotional and energy work, it just helps you open up and receive, yes, challenges are there, but more than challenges, acceptance is very important. So when you accept, okay, this is what is the reality, and now how do I come forward and make the best of what I have? And with the support system, with the family support and the environment, everything changes. So I believe that it's very, very important to take care in all three aspects, not just the physical or emotional, but the mental is very important as well.
Thank you.
Yeah.
Thank you. So basically, we're talking about the energy in the form of how we conduct ourselves, how we view
the
ourselves,
self-love.
how we talk to ourselves, what do we
Yes.
tell ourselves,
Yes,
and
exactly.
the power that we hold within ourselves,
Within us,
right?
yeah.
Okay, thank
Because
you.
this inner,
Yes.
but
So
this
the
inner, the power we have, as a healer, I love to emphasize in expanding it even more, and that magic happens then.
Magic, interesting word. So the three modalities talk about almost the same thing, because both the doctors said that physical health is there's that aspect, and then there's the energy aspect, which is coming in from now the emotional state, and then you're talking about the mental state, and we're seeing how everything is now integrated. So thank you so much. Melanie Joy. I just love your name, first of all. Let me just say that. I love the joy that you bring when you come on camera. So please share your views as well on this.
Thank you so much, Sonia. For many individuals living with a disability or chronic pain, healing isn't always the complete elimination of pain or the absence of a diagnosis. From my perspective, healing is about increasing the quality of life. Success may be sleeping through the night for the first time in months. It may mean walking a little bit farther. It may mean participating in family activities, having enough energy to prepare a meal, or reducing reliance on certain medications. Simply feeling more in control of your health instead of feeling controlled by it. As a holistic clinician, I believe healing is about supporting the whole person, not just their symptoms. That means looking at nutrition, sleep, stress, movement, relationships, emotional well-being, and the nervous system. Because all of these influence how we feel and how we function. Complementary and integrative therapies don't replace conventional medicine. They expand the toolbox. They offer additional ways to reduce suffering, to improve resilience, and help people function at their highest possible level. To me, healing isn't about becoming symptom-free. It's about creating more good days than bad days. It's about helping people reconnect with their bodies, regain hope, and experience more joy, purpose, and participation in the life that they want to live.
Interesting. Thank you. So you again talked about almost the same aspects of the emotional well-being, and then there was the mental where, you know, the stress and everything was coming in. And then you went a step further to say the good days that a patient living with disabilities. And when we talk about disabilities, in the world of disabilities, we have it in different forms. We have everybody who is living with disabilities, as the panelists before us said, they know their body. Nobody knows their body better than them. Nobody understands what they're going through on a daily basis, but they do. And I admire and I salute every single person living with a disability, fighting for themselves, fighting for others, advocating for others. This is why health summits of this kind are so important for the global world of disability. So thank you so much. And I'm sure our viewers have noticed that our panelists tend to have some aspects where they are integrating, and there's some aspects where they have a very different approach to healing. And that is why this conversation becomes very interesting and bold in its own right. What defines it for us? So I'm going to now go into the main questions. It seems, Neil, you'll be my first panelist. I'm just intrigued at how young you are, and yet when I have a conversation with you, anytime I do, you always bring a new perspective to so many challenges that we face on a regular basis, whether there's a disability or not. I believe, as Dr. Dinesh said, disability is not an inability, but at the same time, disability is a different ability. Without my specs, I'm blind. This is my disability of one kind. I am an ADHD brain. I can do 100 things at the same time, but I'll not concentrate on one single thing. That becomes my superpower, and it also becomes my downfall. But now, I want to go into your main question, which is, many of our audience members here, our Rotarians, have experienced an accident, illness, or an event that changed their lives forever. And that happened in a split of a second. How can practices such as sound healing and other multidimensional approaches help support emotional well-being and improve quality of life as they learn to adapt and move forward?
Wow, thank you very much. That's an interesting question. I've worked with a lot of disabilities, as you said, not just, you know, major, even small disabilities like without your glasses. We get so stressed. We get so imagine the ones who've had everything and lost, you know, has become disabled all of a sudden. The emotional impact that happens in the physical, mental, and emotional mind, body, and soul is a trauma, you know, and it changes a lot. So there's so much of emotions holding on. And sound therapy is one of the ways it's a beautiful technique to actually help in energy work and physically, mentally, emotionally to accept the challenges, to de-stress and open up to in a positive way to basically live and accept this challenge that they have in front of them. Because the body is a vibration, right? When this stress is so much, the vibration level becomes low. You're working through a very low pain. You're working through a very low energy system. And sound helps you because our 75% of the element is water element in our body. It's the highest element that is in our body. And sound and water becomes so beautifully integrated. Yeah. So what happens is it starts changing the molecular pattern, starts changing the brain waves. When you're emotional, when you're going through so many challenges of life, the brain waves become so dull. We become so disorientated. This changes the pattern of the body, changes the state and consciousness of the body, and helps them, lift their energy system, start bringing positivity into the body by the cells are absorbing positive energy, because the sound waves that are created with all this kind of frequencies is beautiful healing energies. And your body starts taking in. So you start feeling good. You start releasing emotion and understanding that, okay, it gives you a boost how to face the reality. And when you're healing with all these modalities, like so many different kinds of modalities, it starts changing your emotional state, your physical, mental well-being, because you start feeling good. Once you start feeling good, you start opening up to a beautiful dimension of positivity. It gives you a boost. And that's when you start slowly accepting what the challenge right now is. And what I believe in, what I do, I practice a lot because I've been to so many challenges myself. And I only teach what I have gone through and I've understood to person coming with disabilities or challenges in life is really we need to sit with us, understand where we are at this point of life. What is, we are so fortunate, even with a disability, there's so much good into it as well. So accepting it first, and from there taking it forward and working with energy and all that, if life becomes more positive, life challenges becomes more less, and opportunities become more because we learn how to make the most of it with ourselves. So in the present moment. So that's one of the important factors is living in the present moment. And when you start living in the present moment with energy work, it just supports you. It just brings a lot of love, a lot of healing and openness to get out of the situation you are. And rather than becoming sorrow, sitting there and depressed, all this energy work that you do or any kind of modalities that of mental or physical modalities that help you boost up, basically, to help you become more productive, energetic, and come up with a positive way of living rather than just sitting there and feeling sorry for yourself.
It's tough. We've worked for years with people with disabilities, but I do hear you, because as I say, the greatest warriors in today's day and age are people fighting for themselves every single day and fighting for others like them.
Hello.
I think you got frozen.
I get
I
frozen.
think she's frozen. I guess you're having some issues over there in Kenya with your power.
Yeah.
So maybe that happened. So
Power is okay.
she's coming back. Coming back, I think.
Yeah.
Hello. You can hear me?
Yeah.
You're back. You're back now.
You're back.
Okay. Fascinating discussion, people. It's been really fascinating.
Sorry. Yes. Thank you. Thank you, Mr. President. I think there's a bit of an internet issue where I am. Unfortunately, please, I am really sorry for that. I apologize. So, Neil, you've talked about reflection. You've talked about gratitude.
Yes.
And those are two, it's difficult,
Yes.
but it's possible.
Exactly.
That is something I have personally learned from our group of our team of Rotary Club of World Disability Advocacy. So thank you for reminding us that once again. So thank you. So let's change our approach a little bit. We come back to you, Dr. Melanie, because I want to talk to the doctors after this. As a holistic clinician, and of course the solo female voice on our panel, how can functional nutrition and lifestyle medicine then support individuals managing disability and in particular chronic pain, as Dr. Dinesh had said, that there's some ways that we can help with the physical aspect of it, but then chronic pain comes in different forms and different strengths for everybody. So particularly mothers and primary caregivers, for them, their pain is beyond human capacity, as we would put it. And these mothers and primary caregivers face the unique emotional and physical demands of caregiving while navigating their own healing. We are not just advocating for people with disabilities here or children with disabilities here. We're now also talking about what about that primary caregiver? What about that parent? Yes, we are advocates for our children who have disabilities, as the panel before us did, as Dr. Dinesh was talking about. But from your perspective, first of all, let's understand how functional nutrition and lifestyle medicine supports individuals managing disabilities and chronic pain, and then, in particular, mothers and caregivers, how can we help them through the emotional and physical demands?
Absolutely, Sonia. Thank you so much. This is such an important question. When we talk about disability and chronic pain, we often focus on the individual experiencing the diagnosis. But we don't talk enough about the health of the caregiver that's standing beside them. As a holistic clinician, many of the women that I work with are mothers, wives, daughters, or caregivers. They are coordinating appointments, advocating for service, managing medication, handling household responsibilities, and often putting their own health last. Caregivers often become experts at recognizing everyone else's needs while slowly becoming strangers to their own. One of the most important things I want people to understand is that caregiving itself can become chronic stress exposure, which increases inflammation. Research consistently shows that caregivers experience higher rates of anxiety, depression, sleep disturbance, immune dysfunction, chronic pain, and diseases than other non-caregivers. In fact, research from the caregiving literature has shown that chronic caregiving stress is associated with increased inflammation and immune dysregulation. Studies have demonstrated that chronic caregiving stress alters immune function and increases inflammatory markers. This helps us understand why caregivers often experience declining health over time. What I appreciate about functional nutrition and lifestyle medicine is that they ask different questions. Instead of asking, what disease does this person have? We ask, what is burdening this person's physiology? What is depleting their resilience? For many caregivers, the answer isn't one thing. It's often a combination of sleep deprivation, chronic nervous system activation, nutrient depletion, blood sugar instability, a lack of movement, social isolation, and emotional exhaustion. When we begin supporting those foundations, we often see meaningful improvements in quality of life. Sleep, as an example, is one of the most powerful yet overlooked interventions. And the research consistently shows that improving sleep often improves pain, mood, cognition, and daily functioning. Nutrition matters too. Dietary patterns rich in protein, vegetables, fruits, legumes, fish, olive oil, and nuts, and minimally processed foods have been associated with lower inflammation and better overall health. The goal is nourishment. I tell my clients all the time, your body isn't asking you to have it all together. It's asking you to be cared for. Sometimes success looks like adding protein to breakfast or sitting down for one balanced meal a day. Sometimes it's taking those small changes matter because overwhelmed nervous systems often respond. Another area I focus on is the connection between chronic stress and the nervous system. Many caregivers live in a constant state of hypervigilance, waiting for the next appointment, the next crisis, the next phone call, or the next symptom flare. Research in psychoneuroimmunology has shown that chronic stress influences inflammation, hormone signaling, and pain perception. This is why lifestyle medicine includes things that may seem simple, but are biologically powerful. Walking, time outdoors, breathing practices, social connection, gentle movement, mindfulness, and restorative sleep. I also think it's important to acknowledge something we don't discuss enough. Not every symptom is a nutrient deficiency. Not every symptom is psychological. And not every symptom requires another supplement. Sometimes the body communicates that it has been carrying too much for too long. Before I close, I'd love to leave caregivers with 3 practical takeaways. Nourish yourself before you nourish everyone else. Those small acts tell your body that you matter too. Second, schedule appointments where your only job is to receive. Whether it's massage therapy, acupuncture, craniosacral, or another restorative practice, make those appointments a part of your healthcare, not a reward you have to earn. Caregivers spend so much time giving that they often forget what it feels like to receive.
Mm.
And finally, don't wait for life to slow down before you care for yourself.
Mm.
Many caregivers tell me, I'll focus on my health when things settle down. But for many families, that season never comes. Instead, build small moments of restoration into the life you're living today. 5 minutes outside, a short walk, calling a friend, going to bed a little earlier. Healing begins with consistent acts of self-care. Functional nutrition and lifestyle medicine are not replacements for conventional medical care. Rather, they are tools that help us support the whole person. When caregivers are supported, everyone benefits. The child benefits. The spouse benefits. The family benefits. And the community benefits.
Thank you. You spoke to, I know you spoke to many, because this is something that a lot of the caregivers tell us, that we forget ourselves when we are caring for our loved ones. I know I'm saving the best question for the last, for sure, because I keep imagining what happens to a mother who's just given birth and, you know, and sees her child with pipes and everything. I keep asking myself, what is going through this mother's heart? What happens to a mother who's just given birth and she's told that your child will live with this condition for the rest of their lives? And as Neil was mentioning, that it's acceptance. And that is the hardest part of parenting. The hardest part of advocacy is acceptance. So thank you, Melanie, for reminding us, joyfully that is, reminding us that we really do need to take some time out for ourselves. Healing also begins with how we treat ourselves. So thank you so much for speaking for them and reminding us about the nutritional value of what we put into our bodies. It's very hard. There's a lot of stress eating that we do. And so it becomes very difficult for us to put ourselves in their situation, in their position. But what we can do is create community for them. We give them a support system that they can rely on. Just give them a shoulder to cry on or an ear to listen to them. So thank you for reminding us about that. Thank you so much. Dr. Dinesh, you know, there's something Melanie said that is connected to your question. So I do know the right way to address you is Vaidji, which is a title given to the doctors who have undergone the Ayurvedic healing, training, if we may call it that. We know that Ayurveda and yoga, which has taken the world by storm, I must say, it's become a global phenomenon. When you look at the International Yoga Day, how everyone is celebrating it, everyone has embraced it. It's so beautiful to see how humanity has embraced each other's way of working. And we know that each one of you, by the way, is talking about an ancient wisdom. So, Dr. Dinesh, Ayurveda and yoga emphasize treating the whole person rather than suppressing a symptom. And I'm not saying that that is what happens in in the medical fields, but I'm saying more or less it is even us ourselves who do not come forward and say, I am going through these challenges. And that just keeps on adding into issues. For example, if my knee is hurting and I keep ignoring it, eventually I'm going to have a challenge, and disability would also come in old age, not just somebody young. It happens with the older patients as well, when their bodies are not able to sustain the strain over and over again. So for such individuals living with permanent disabilities, managing chronic pain even in old age, how can they use basic Ayurvedic principles, gentle yoga, to listen to their bodies, restore internal balance, and ultimately live a more meaningful life despite the pain that they're going through?
Basically, I think the panelists before me, they have already mentioned, I think, 70% of what I wanted to say in terms of energy. And so basically, when somebody is living with the pain and the stress related lifestyle, what happens? Your body gets adapted to that sort of stress memories. So to them, it is like it's a normal thing on day-to-day life. Suppose if I'm suffering with the knee pain, the mild knee pain, it's like it times comes that I've accepted it, there is that pain. So the body gets accustomed to that sort of memory, that this is what it is. So whereas one has to also understand how to re-educate your body to relax. The stresses are always there in day-to-day life. We live in an era where stress is inevitable, but how you can increase the threshold capacity of your body or the body of patients to absorb more stress and tension, rather than saying that don't take stress, because stress are always existing one way or the other. Whereas now Ayurveda and yoga comes in, as I said earlier, Ayurveda is basically a science of an entire lifespan, the knowledge of a lifespan. That's what Ayurveda means. And Ayurveda means that human body is an epitome of Mother Nature. So creating a synchronization with the nature around you in terms of breathing techniques. I think someone also mentioned that the breathing techniques helps you to synchronize your two nadis, Ida and Pingla, sun and moon, yin and yang. It creates synchronization. Yeah, there are different techniques of breathing in yoga where you can balance your nadis and also the energies within the system. So performing that yoga gentle breathing techniques helps you to resolve so many of the stresses within the body. Like Bhamri, when you close your eyes, close your ears, and just chant a humming sound of Om, gives a tranquil feeling of the entire nervous system and the body. So there's so many asanas, there's so many breathing techniques in yoga to create harmony and synchronization with nature. The same way Ayurveda, in terms of herbal preparations and the day-to-day living, as I said earlier, that dietary regime, my first prescription to all my patients is diet, because what you eat is what you are. Basically, if you're going to eat junk and diet that is going to consume a lot of energy and time to digest within your system, it's going to deplete your inner energies, because every grain you put needs energy to digest, assimilate, and utilize. So it is very important what you are going to put into your body and what you're going to get. So dietary regime is very important in maintenance of your health and vitality. The same way, gentle stretches, guided stretches, yogic chair yoga, or all this for the people with pain and disability can help to improve movement, reduce stiffness. Diet can help to reduce inflammation. Inclusions of something like turmeric, ginger, clove can help to reduce inflammation and vata. As I said earlier, the three doshas, vat, pitta, and kapha, are three constitutional energy, what makes you as a person. The same correlation you give it, that it is yin, yang, and chi. That is vat, pitta, and kapha. It has the same characteristics in both the modalities. So it is how you create a synchronization in all the three doshas through your diet, through your dietary regime. Your daily dincharya, which is a Sanskrit word, means that your day-to-day activities, the time to sleep, time to eat, time to relax, time to get up. If you have a specific time, which is your daily routine, exceptions can be there, but on a normal basis, if you can create that sort of routine lifestyle, it helps your body to adapt, heal, and synchronize the energies which are not in balance. Then, listening to the body's wisdom, what is aggravating and what is calming. So you learn to listen to the body. I always tell my patients that you have to become your own doctor. We are here to guide you. We are here to share whatever knowledge God has given us to share and help you, but you have to listen to your body. Because I think earlier panelists say that a person who is suffering lives with their own body, so they know better how their body is working. So here the wisdom of listening to your own bodies comes handy for you to handle these situations. Now, the most important thing is that physical disability can limit the movement, but it can always be improved by looking after it or working on it. So I just, if we go on to this subject in detailed wise, it becomes so long. So I'll just summarize it in simple way. Ayurveda and yoga looks at how to harmonize the body. Is three energies, that is Vata, Pitta, and Kapha. Basically, Vata is responsible for the movement, stagnation of energy, stagnation of circulation of blood, fluids, lymphatic system. So if Vata is vitiated, it will cause obstruction, it will cause wear and tear. So once you reduce that, I think Dr. Glenn mentioned about energy stagnation. When the energy is not flowing properly, the movement is restricted. The same way Ayurveda believes that when Vata is stagnated or Vata is vitiated, it either causes obstruction or excessive movement. Like in Parkinson's conditions, there is excess Vata. So the movement is uncontrolled, and it is the people who go through Parkinson's, they have a terrible sleep pattern. They cannot even eat properly. All those things, it's because of excess of Vata. So if you can create that equilibrium of three doshas, Vata, Pitta, and Kapha, the harmony of the body will automatically be there, because Ayurveda believes that the human body is an epitome of Mother Nature. When there is heat outside, there is heat inside. When there is rain outside, there is more water inside. When there is cold outside, there is cold inside. So listening to the nature and the body, there are so many ways of doing it through even herbal preparations. Like there are herbs like Triphala. It is a combination of Amla, Herde, Berde. These are three myrobian fruits. So it has a powerful impact on the body to synchronize the three doshas. So Triphala actually balances Vata, Pitta, and Kapha. Yes, it has other benefits, like it works as a mild purgative laxative. So there are simple herbs like that also can help you to create balance. Then there are herbs like Nirgundi, which you can use it as a hot fermentation poultice to reduce Vata. Can be taken orally also to reduce Vata so that it reduces inflammation and pain. So Ayurveda has it is an ocean of knowledge as far as the health is concerned. And nobody knows when it was not existing. People said that it is 5,000-year-old, 10,000-year-old. But as far as when I'm studying the Ayurveda more and more and more, it is, you are coming to understanding that there is no time that it was not existing. It has been there since the time of creation of this universe. So what we could look at it as Ayurveda is concerned and the yoga is concerned, the simple breathing technique, the gentle asanas, gentle chair yoga movements, and guided stretches, and dietary regime, and gentle oleation. As I mentioned earlier, that Simsim oil is considered to be the best anti-Vat oil. The same way honey is considered best anti-cough remedy. And ghee is considered, the clarified butter is considered as the best anti-pit element. So that way, there are so many things which you could implement into your day-to-day dietary regime, which can help you to create synchronization and equilibrium of the doshas.
Thank you, Doctor. You're right. It is an ocean of knowledge, and you're right. When we work with nature and not against nature, we feel good. We feel better. I know there are other countries that have the 4 seasons, and the global, weather pattern changes affects us. It's true. You're very right about that. So thank you.
In fact, Ayurveda also says that one should eat as per the seasons. There are different fruits, there are different dishes you prepare for different seasons. So Ayurveda has gone into the minute details of what you should eat in the morning, what you should eat at lunchtime, what you should eat in the evening. In a rainy season, what sort of food you should eat, and what are the methods of preparations in certain season for certain foods. So it is an ocean of knowledge. So for me to even go into the details of those knowledge, I think even the session will become boring and it will be too saturated. So I think, and if there is any other question you want me to specifically answer, otherwise I will leave it to this for the time being.
Thank you. I am being reminded that we're out of time. I did inform the team that I know this session will go long, but thank you so much. Thank you so much again for your shared so much, and I'm hoping that our audience managed to get some notes down. Dr. Glenn, you have intrigued me, you've intrigued my team to a different level, because as I said, we've saved the last question for you, because this is something even we had not thought of when we were talking about advocacy for people with disabilities. You care for some of the most fragile patients imaginable to humanity. As a physician who embraces energy healing, how can conventional medicine and complementary approaches work together to provide compassionate, holistic care, especially when outcomes may include lifelong disabilities despite our best interventions? That is my first question to you.
Thank you. With this, I know we're out of time. I give the very short time I have. Let me just go into the deep dive into what my alternative work is, which is pranic healing. Pranic healing is an energy work. It's the fastest growing energy modality in the world, available into over 120 countries. We have it in East Africa, in Kenya, in Tanzania. We have it in West Africa. We have it in other areas also in Africa, and what was mentioned earlier of the Global South. It's been practiced not only by physicians, but actually anybody who would like to learn about energy work. So it's a global work that I have. We could apply it actually, as have mentioned, I think what Thomas William Shakespeare in his keynote mentioned something about it's difficult to have a disability. It's very difficult to have disability. So we apply energy work. We could take care of pain. I did a major study in a quaternary hospital here in northern New Jersey, wherein we take care of pain in emergency room. So we could remove some of those pain. We could remove some of those difficulties. So we realize people go to the emergency room. They don't go with a toothache. They go with a major problem. And what happened was that given with pranic healing, with the medications, with narcotics, it's even better than just the narcotics alone. That's one aspect. What I'd like to take care and probably submit and address to the group is one of the difficulties when we have somebody sick in the family, the whole family structure is affected. Mm-hmm. Just think about it. If one is sick or in the hospital, everybody gets affected, even the child. So I'll tell you a story. I was in India one time and a plastic surgeon came to me. I said, Master Glenn, because of pranic healing, I said, I have a patient who had multiple surgeries on the face because she had severe burns. What can I do? He's the plastic surgeon. I said, what am I going to do? I said, I'm not a plastic surgeon. Then I think what my area is, I said, do meditation. Tell her this. I teach meditation. What happened was that tell her to do this meditation. It's called Meditation on Twin Hearts. Just do this meditation every day. And at the end, the meditation will not open only one's heart, but also do some healing. So I said, in the end, I want you to bless, number one, those who have been affected by cancer on the face, by injuries on the face, by any deformation in the face. And at the same time, I want you to bless all those beautiful people that you'd like your face to be in, the actress, the idols that we have. 3 months after I went back to India, this plastic surgeon has been looking for me. I said, I just want to let you know that patient is healed. She goes outside now. She feels good about herself. She accepted herself. So, and bottom line, on the lens of care, those who have disability, do meditation. Do meditation. Look at Meditation on Twin Hearts. It will change you inside. You will accept who you are as is. And somehow there'll be healing on that aspect, energy healing. Because the health will not only be on the physical level, not only on the emotional level, not only on the mental level, but only on the spiritual level. Thank you.
Wow. Okay, interesting. Wow. Okay. So again, it goes back to how do we heal ourselves? What do we tell ourselves when we're meditating? How deep do we dive? Thank you for reminding us about that. I mean, that's awesome. So I'm coming up with a very, very tough question for you, Dr. Glenn, but I know you're ready for this one. How do you help families understand that healing and wholesome can still exist, even when a cure is not possible? Because I keep thinking about the child in the NICU. I keep thinking about what is this, as you said, the whole mindset, the whole, the whole person changes in the family, the energies, everything changes when one is hit with the news the first time that maybe there's no cure for this. how do you help them both as in your capacity as the doctor, a medical doctor, and then as a healer? How do you manage that?
Thank you very much. It's a very difficult. I've seen a lot of babies that are born severely deformed. They could have Down syndrome. They could have other multiple anomalies. Number one, I approach it on of course, it's a baby, and I just have to approach it on that aspect, and also look at it from the family's point of view. But this is just my selfish way. I just focus on what's best for the patient. Then later on, extend it to the family. On an energy aspect, on pranic healing aspect, or a spiritual aspect, sometimes we are given in a difficult position. This is all for those who have disability. We are given in a difficult position, but we don't know why. Sometimes it's not, this whole story is not given to us. So that's why I opted for some meditation, because sometimes you could see inside, this is who I am. This is what my lessons are. And to me, that's important. So for those who have disability, as Thomas Shakespeare said, go into grassroots, give it into your community, let them learn how to do that. And it's a difficult thing, and I salute the Rotarians International Rotary for this grassroots of disability and advocacy for those who need help. Thank you.
Thank you. Thank you so much. I know the audience wants us to go on, but we have to respect that there is one more panel waiting up. I keep seeing their images popping in, and I honestly do thank each one of you. I know we are leaving this session as better human beings. We're leaving this session as better advocates for ourselves and for our loved ones. And we're leaving this session as better advocates for others. Each one of you has reminded us that indeed the power of healing is within us, and that we need to understand ourselves. We need to understand people who are going through these challenges. If we understand that, there'll be no stigma. That was one of the biggest challenges the policy panel were discussing, stigma. If we just accept ourselves and accept each other, there would be no stigma. There'll be no discrimination. We would understand that this person in front of us is suffering, and we're here to help them out. So I do know we had a question after this, but I've been told that we are quite up on time. So allow me to share this reflection. To move beyond roles and disciplines and speak from shared humanity, where care, dignity, and presence meet. We believe this will create a thoughtful and uplifting close, reminding us of the heart of all care, improving quality of life for every being, every person. So with gratitude, we, the Rotary Club of World Disability Advocacy, would like to thank each one of you for sharing your time, your wisdom, your experience that has helped shape the outlook of many of our own who are struggling with chronic pain, finding solace, and a safe space amongst their own thoughts and words. On their behalf, we thank you for your passion, gift, and vocation, and encourage you to keep spreading your beautiful life and heal the world. We look forward to another meaningful and enriching discussion with you in the future. I assure you of that. Signing out, Sonia Kaur-Rajbans, the Chair for Inclusive Education Pillar for the Rotary Club of World Disability Advocacy. Thank you so much. Atma Namaste. Thank you.
Thank you, Sonia, and your panelists. Feeling a bit healed after listening to you guys. And worth the time, really. I know it's not enough, and I look forward to listening more about alternative healing in other sessions that we plan to have for our club. So Sonia, please make sure you invite the panelists again so that we can have more time with them.
Definitely. Thank you.
Yeah. All right. As we close this third session, we are on our fourth panel session, which is the last session of the day. This is about technology, because technology continues to transform the lives of millions of people with disabilities, creating new opportunities for communication, accessibility, mobility, independence, and participation. This session explores innovations that are helping people live more. Please mute. Someone is on, please mute.
I think we're okay now.
All right, thank you. This session explores innovations that are helping people live more empowered and connected lives around the world. Moderating this session is Daniel Roda from the US. We call him Dan. He's an accomplished educator, composer, performer, and vocal coach whose work beautifully bridges music, special education, and mental health advocacy. He serves as the Chief Academic Officer at the David Z Foundation, using music education as a powerful tool to support young people and promote well-being. A passionate advocate for universal design for learning, Dan is dedicated to creating inclusive environments that embrace diverse learning styles. His unique blend of artistry, education, and advocacy continues to transform lives and inspire communities around the world. Please join me in welcoming Dan, who will introduce our exciting panelists as we discuss technology expanding access, independence, and choice in disability care. Welcome, Dan, and your panelists.
So wonderful to be here. I've been really looking forward to this day, and I am just thrilled to have this incredible panel. So we were going to start with a music video, and hopefully we'll be able to roll that in at the end. I think it'll actually be a really powerful punctuation to our discussion of how we can use the technology of just creating media to create healing and to build community, and especially considering the global community. So I am going to go ahead, do something a little bit different. I'm going to have each of my panelists introduce themselves and tell a little bit about what their perspective is. And I think one of the huge strengths of this panel, and just to kind of ground us in what we will be talking about, are some of the challenges that technology can bring, but moving to the opportunities that technology can bring. And I think we have to navigate those things together. There's really no training wheels on life. It happens just all at once. So I just wanted to give us a trajectory of, hey, let's be real. Let's say what's going on. Let's say who we are and what we're seeing. And then let's have this discussion about where we can go together. Just one thing real briefly that I had noted myself in thinking about some of the questions that I'll be asking and some of the questions I asked the panelists to consider ahead of time is, number one, any discussion that we engage with, especially globally, it's a good question to ask what we bring to the table. So like, why am I here? Why am I at this table? And the second really powerful question to ask is, who's missing? And then the follow-up to that is, what are we going to do about it? What are we going to do about it? So I wanted to first pass the mic over to David and Christy Cohen. And Christy, it was so great to touch base with you a little bit yesterday. Why don't you go ahead and introduce yourself, and then David, you can. We're going to go from David to Elpida to Tay to Tanya, and then we'll get this party started. So hello, Christy and David.
Hi, Christy.
Hey, Christy.
And some things I gotta trust, but okay. But like I talked to Dad last night, about things, ideas, and stuff like that. I've done another thing after I talked to Dan 2 times, but making music would be good. Art is like really good. But I've been with Counseling Center and I do pretty good with that.
Yeah. Well, Christy, one thing that we, oh, sorry. I was just going to say one thing that I loved in our discussion last night. We were talking about what happens when things change, you know, and that happens all the time in the healthcare industry. It happens all the time in schools. It happens all the time in life. So what is one thing that helps you when things change?
I'm gonna hard, but I can try. I really don't know.
That's okay. We can pass it to David, and then if you think of it, you can tell us, or we can just move right on to Alpita. So I'm so glad you're here. David, why don't you go ahead and introduce yourself, just kind of what your professional background is, and then what's one challenge that you see in the healthcare industry as a big conglomerate system?
Hello there. I'm David Cohen, a doctor of clinical psychology, a priest of the Episcopal Church, and a professionally trained clown. I'm also Christy's father. We live in a town in Northern California so small it doesn't even have a stoplight. A town so isolated we don't even have a Walmart. We use technology frequently to connect with medical personnel throughout the state. However, the technology that is available is always limited. There's simply, in many cases, there simply is no substitute for an in-person appointment. And we live, because of where we live, many of the specialists we have to see are hours away by car. So we're interested in expanding access to medical specializations for people in rural communities. Would you say that's right?
Yeah.
Yes.
Well said. Awesome. Well, and that's a perfect segue into our next panelist. If Ms. Alpita, if you would introduce yourself. And I think that's, you know, speaking of telemed.
Yeah, absolutely. Thank you for having me. And I appreciate being on the panel. I look forward to actually opening my, or getting more to know through other panelists. I've spent most of my career working in healthcare technology and community outreach, essentially. And I have been really passionate about finding practical ways like to improve access to care, essentially. Not replacing the human connection, but strengthening it. So I've spent quite a bit of my journey helping patients connect with providers, and how David said there is a lack. So I really enjoyed helping folks like him and other folks to create a better opportunities for better outcomes. And I'm excited to learn from my fellow panelists today and to contribute to today's conversation.
Awesome. So let's move on over to Tay.
Hey, yeah. Firstly, thank you so much to Rotary International. This is a fantastic panel. But I'm Tay Zonde, a singer, voice actor, educator, and a disability advocate. I'm a member of the Disabled Voice Actor Database. I coach voiceover at skillshub.life. And in a prior phase, I was a humanities academic. And very happy to be here.
Awesome. And yeah, we kind of both are in the entertainment industry as well, just in music. That's one of the things that we kind of nerded out over, and we'll get back to music later in this discussion, I'm sure. Last but certainly not least, but probably the furthest away from anyone is Miss Tanya Ramming. Go ahead and introduce yourself.
Hi, thank you, Dan. Yeah, my name's Tanya Ramming. I am coming at you from Fort Bidwell, California, which is the town that is the most northeast in California and still in California. We're about 26 miles from a grocery store or a gas station. There's no public transportation here. And so I'm working at the Warner Mountain Indian Health Clinic in Fort Bidwell, which is it's on the tribal land of the Giduptigad Band of Northern Paiute people. And so it's a really interesting place where we have this mix of indigenous and I call it the cowboys and Indians. It's really the theme of our county is where the West still lives, and it really does. It's pretty wild. So my background is as a school counselor, but now I'm working in the clinic in community supports, and we see a lot of challenges when it comes to just distance. We don't have any broadband here, so internet access, even having smartphones, and so I don't get any cell service in most of the valley where I live, and we're surrounded by mountain ranges on both sides. So besides being physically isolated, it's difficult to travel in the wintertime because it does snow here. So just the access issue here is really a challenge. And then I would say the other challenge with technology is kind of this cultural challenge. The people here, and I'm going to say probably in most of the United States, Indigenous people have been treated very poorly by the government. There was a history of forced sterilizations, of boarding schools. And so anything that comes from the man is always taken with suspicion, and that includes Western medicine. And so I think that using technology in a way where we can connect Indigenous people to Indigenous professionals has been really life-changing in terms of access to care and health outcomes. So that's all I'll say about that. Thank you for having me.
Absolutely. Okay, so I am going to just be myself and do things a little bit differently because that's how I roll. I'm actually going to inquire the audience, and I would love to hear actually there's Q&A box that you have access to. I'm going to be asking you questions. I want you to answer them. So as we go through, I do want to kind of populate that box with what are thoughts of people here. And I'll ask the questions twice because that's just something that always helps me. And I'm imagining it might help someone else too. So our first question is really helping us understand the landscape of technology within the healthcare system. What are some of the most persistent barriers, structural, financial, cultural, or technological, that you have observed affecting equitable access to care in your work or community? And I'll read it again, but panelists, we're going to do popcorn style. Whoever wants to start, just come on in. So the question is, what are some of the most persistent barriers, structural, financial, cultural, or technological, that you've observed affecting equitable access to care in your work or community? So audience, you're on the line too. Who would like to start with that? What are the barriers, most persistent barriers?
So
I'm happy to
I
take
can.
that.
Oh, sure.
Yeah,
Go ahead.
I love
I
it.
mean, speaking from the perspective of entertainment, Hollywood, entertainment has a problem with performance expectations that don't get included in audition specs and job descriptions. Maybe a job wants an actor, but, it also wants them to do press junkets, also wants them to go to conventions, also wants someone who can make lifestyle content. And, those are separate jobs that are each affected by disabilities and care needs. So, one issue is that disability advocacy needs to take invisible expectations that get culturally tacked onto jobs and, make those explicit, define them as part of that job. And then there's obviously, as with many industries, very high concern about AI and AI replicas. And I think another kind of factor in the background is that as we live through very valid technology concerns and sometimes even an anti-technology backlash, we should always keep in mind the ways that technologies can be empowering and help facilitate inclusion for people with disabilities. So.
Yeah, that's awesome. And I think a really great touch point to the prior panel with the anxiety that can come about, not just for people with disabilities, but for also caregivers, for just a wide variety of challenges that people might have. There's untold anxieties about even getting in the door. So I think that's a really great place to start. Alpida, I think you had something too. Go for it.
Oh yeah, just like Tay said, and it's essentially lack of access to correct information. How technology can actually build its boundaries and make sure that it also maintains its boundaries, but it's all across sharing information like of a person who's disabled all across the country, rather than having him if there's an expert which is available in Massachusetts and the person is living in California. So just having that sort of bridge where they could access the information. So it has a lot of growth to grow, but also to penetrate. Tech has a lot of opportunity to grow and penetrate in itself. So yeah.
Amazing. And from the audience, there's a few comments. I'm gonna leave everything anonymous right now, but one person said, the culture in my community, they don't embrace it. We still believe in traditional model service, deliver accompanied with technology. For instance, healthcare is best provided in my community physically, then followed easily with technologically. So I think that's a rapidly changing part of medicine is what is the role of online? What is the role of WebMD? What is, when somebody has a symptom, they look it up and then all of a sudden they're diagnosing themselves, that is a problem. And somebody else, for their child, our families experienced several barriers accessing services and supports, including delays caused by insurance requirements, repeated requests to provide documentation, and difficulty in finding providers who accept our insurance. So that financial piece as well.
Hear, hear.
Yes. Do you want to add anything to that, David or Christy?
Christy is officially on state insurance, Medi-Cal, and as with anything having to do with the state, it's an incredibly involved process to get prior approval for medical appointments. And remember, for some of Christy's specialized appointments, we need to go all the way to the Stanford Hospital, which is 7 hours drive each way on a good day. And we may not get approval until the day before the actual appointment. So I strongly echo Tatum's concerns about accessibility. Right? Okay.
Did you want to add something, Christy?
You want to talk about the doctors you see at Stanford? Keep the fingers up.
The doctor going really well. Sometimes I don't like shots, but I have to do it. But I get used to it. Pretty much every day, but almost every day. But anyways, my question is, I need everybody name. I know Dan.
Okay. Their names are there in the box.
Yeah, I know.
Okay.
So one on the white. What your name?
His name is
Tay.
Hi, Tay. Nice to meet you. So before Dan moved and her daughter and her husband, I worked with Dan at the high school for a really long time, and I love him very much. He is a very good teacher.
I didn't pay her to say that, I promise.
And
Chris,
so with then and over, I'm really sad because I love school. I know.
so Chrissy, just a quick question, then I want to pass the mic to Tanya if you want to chime in on this, and we'll move to the next question. So you guys mentioned Stanford, right? I know
Yes.
it's a long way from where you live to Stanford. So what are those long car rides like? Is that that's kind of a big thing, right? Like
Yes.
the opportunity cost. Yeah.
To clarify, Christy was born in the Monterey area and was seen by the folks at the Lucille Packard Children's Hospital before we ever met her. Christy is adopted, so they've been caring for her entire life, and we've decided to keep her case there because they've known her all of her life.
Yeah, continuity.
But the car rides to Stanford are very long, aren't they?
I sleep a lot, but in a car
Nice.
sometimes. So yeah, a long drive. Sometimes they Airbnb the house. Sometimes they at the hotel. And the appointment is going really well for me. I'm saying that. So yeah.
But I think just to kind of put all that together, there's that opportunity cost, not just of the driving time, but also like there's the getting in the hotels, there's the having to get people to take over for you at work or whatever you have to do, and then there's that being away. You're kind of in like satellite mode. But then on top of that, there's that we do this a lot. It's not like we do this every few years. It's like every few months.
Or every
That's a
day.
big difference. Or every day, yeah.
The standard is, don't do that, please. 2 times a year. Sometimes we have to make 3 trips because we can't always get all of the appointments together at the right time.
Yeah, absolutely.
In right day.
Yes.
Yeah. Tanya, did you have anything on this, kind of looking at those persistent barriers? And we actually have already covered my second question, so we're rolling right along, which is about the impact of these things. You know, what is the impact? But yeah, anything else you wanted to add in?
Yeah, I think just maybe considering, and this is probably like true in many rural places, we're always like 50 years behind everyone else. And so the healthcare system is really designed with the clinic or the doctor at the center of it, and just filling up that schedule with patients, never asking the zip code of the patient or where they're coming from or how long or how many barriers it took for them to actually get there, right? And so I always try to advocate for being more patient-centric. At our clinic, you know, we have to arrange transportation. A lot of people don't have vehicles. And to do that, you know, oftentimes we'll have partnership cancel on us because they don't have a transporter who can come all the way out here and drive to Sacramento, because yeah, a 6-hour drive one way involves a hotel stay overnight, and things like that. So I think there's kind of 2 things that came up for me, is just that our system is not patient-centric. And then also we have a big generational divide. In California, at least, a lot of Medi-Cal, Medicare is all online applications. And our elders do not have computers or don't know how to use their smartphones, and having to set up, you know, a Covered California or a Cal Benefits profile online just to access services and apply is a huge barrier. And oftentimes it just takes that live in person to kind of make the connection. So where we're at, you know, we have technology, but having access to technology online isn't enough. You really need a human to sit with you and show you how to use it and walk alongside you. And I think that's what's really missing in a lot of this technological advancement is going so quickly, and it's leaving a lot of folks behind because of that disconnect.
Yeah. Well, I want to read between the lines there. You need not just a human, but a patient and kind human that knows
Thank
where
you.
to to help you navigate. Because a lot of times when you have a very isolated system, pieces of the system that are not connected or like cross-connected, we're going to miss that continuity of care that we started talking about too. Of you feel like you're just going through a machine and you have to do this and this and this and this. Okay, I checked all the boxes, and then finally you get to say, hey, this is who I am. This is what, some other issues that some of our audience and attendees have pointed out: access to mobile phones, capacity in telehealth, finding resources, that we have to find our own resources. You have this kind of disparate, disconnected network of agencies as well that all have to somehow align at this one time for this one person, for this one thing. And to advocate is constant, which and very important, and time-consuming, overwhelming, lack of access to internet, and especially in rural communities and throughout developing countries. So, since we've already handled a lot of the effects, yes, Tanya, go ahead.
I was just going to add the social media aspect too, because I think that that's one of the first things people access, which isn't always correct or good quality information. So
yeah, and that there's the mental health impact all throughout, whether you are going for something that is more physiological, whatever your appointment is, or if it's there's always going to be that psychological and psychiatric and mental health component to it, because we're bringing a full human into another room of full humans. Like that's what I like to think of school is. First see the room full of humans in front of you, and then your role as a teacher becomes more clear what you should do. I imagine it's the same with doctors and with other care professionals. So I want to just kind of live there for a little bit. We're already starting to turn the corner and be solution minded, and talking about individual agency. So in what ways can we, by ourselves as individual practitioners or patients or community members, contribute to improving healthcare accessibility without waiting for system level reform? Because that's easy to do, right? It's easy to say, well, this is changing, this is getting fixed. Like, well, what are we doing to fix it? What can we do? Anyone want to hop in on that one? I'll Peter, you unmuted, go for it.
Yeah, I was gonna say that, I think when I was working at Psych Online, which was a mental health platform which we built for providers to easily access patient information. And what I saw there is that the providers, especially the doctors, wanted to provide the care, but the education was the part that was so these small improvements, small pieces of education where we actually educate the patient and help them build that telehealth file of information that they need to build for themselves. So, I think that is very, very key, to so just having small pieces of education, continuous education to the patients would definitely help, and better communication. I think the better communication, education would help the agencies as well. So.
Yeah, and that sharing of information that can often feel very invasive, as the patient or client or even caregiver, how many times you have to say the same thing. And I guess that's my other question, is how can we create systems that are really patient-centered, and I think that's just a beautiful way to frame our experience in the healthcare system, that it is centered around us and not the agents of the healthcare system. What can we do to have that a document that we can share easily that has the answers to a lot of these questions in a narrative that makes sense, and we can keep updated, and we don't have to feel like we've given all these different answers to different people. That's interesting, opportunity. Tanya, did you want to pop in? Oh, go ahead. We'll go Tay, then Tanya.
Sounds good.
No, I was just thinking, I mean, something that I think that I experience as being very helpful in medical care spaces and other contexts is, I think, just empathy for some of the education burden that I experience as a disabled adult, as a special needs adult. I think especially in entertainment and where public branding and social media is a very big factor, there can be a tremendous pressure to self-diagnose and to validate self-diagnosis. And so I think that's kind of an issue where I've been privileged to have access to the apex of Western medical care my entire life, going back to childhood. But there's also kind of this sense of like, to what extent is formal diagnosis, sort of a type of freedom paper, a type of like, okay, I'm card carrying. And then just when I enter a space that empathizes with some of the education burden that I face, and just explaining my own experience with invisible disabilities, that's something that I very much appreciate, because it's not a one size fits all type thing. I mean, using myself as an example, I can enter every space and say, hey, I'm autistic with dyspraxia, misophonia, haplophobia, and ARFID, but that's I might as well be speaking Egyptian. Nobody really knows what that means in terms of accommodations, in terms of special needs. And so I think just some awareness in that space that different needs might present, and hey, we welcome those. We welcome that conversation about what are each individual's particular needs. So
I love that. Yeah, I think too, kind of as what you're talking about, Tay, is trying to offer information multiple ways, and making that just part of how we do with everybody. Really everybody would benefit from hearing it, seeing it, receiving something in writing, practicing it. And so I think in terms of technology, the way that we try to communicate with patients is always threefold. We always do three things saying the same thing. Hopefully one of those things will stick. I think another aspect of kind of working with folks is really just bringing joy into it. Healthcare can be really heavy. Sometimes it just feels heavy. And if you can have fun, I like to have fun with food. I believe food should be part of every outreach. And I think that that's just another way that we can celebrate culture, who people are, and bring people together in a fun way, but also include that information. And then lastly, I would just say that I've learned a lot here working for an Indian health clinic, because the design of healthcare is different than in a traditional clinic or hospital. And I really love that it's like a centralized and decentralized. We have community health reps. That design came out of, well, I'm sure it was international. I know of the Navajo Nation really used that design when the polio vaccine came out, and they had some of the lowest rates of vaccine on the reservation because people, of course, did not trust the medicine, right? And so what the Indian Health Services, the hospitals and clinics on the reservation noticed that, when they talked to the grandmas and the aunties and could explain the science to them, all of a sudden, then the people were convinced, and it was okay because it was coming from a trusted source, right? And so their vaccine rates really increased when they were able to employ people within the community that had trusting relationships already, because they were inherently integrated into that community. And that's how we work here. We have a community health rep right behind me here, Serena, who is able to go knock on doors. And when she knocks on the doors, people open the doors. They don't always open the door for me, but when Serena's there, right? Yeah, they always open the door. So I think that really using the strength of our communities is really important, and kind of decentralizing, having that case management, that person that follows a patient through all the different appointments and is that advocate saying the same thing, helping that information get spread is super, super helpful.
Yeah. Oh, go ahead, David.
Yeah, mute.
There we go.
I was actually just checking the questions and answers because I'd seen a new one had appeared. But Christy, did you want to say something?
I think I really like Tatum and Dan because they connect together. And then idea to connect to Tatum, and I am a homeschool with Tatum. Noah is young. He does not talk.
Okay, we're not talking about
I know.
We're just talking about you.
Yeah, I am. Please
Go for it, Chrissy.
So I'm a homeschool, like I said. So I work with Noah.
Okay, we're only talking about you. We're not talking about other people.
And so, and I like it. I like being a teacher. And first thing, like I thought it was hard, being a teacher, and it kind of is, but kind of easy too. So thank you for me having Tatum and work with Tatum, Dan. Thank you.
Yeah, well, actually, I love the point you're bringing up, Christy. And just for some context, Tatum and I were co-teachers in a high school. We actually worked with Tanya, which was awesome. And Christy was someone in our classroom that was not just a content creator for giving all the examples for what we did, but also worked directly with students and would be kind of this force showing that it has to be a two-way street when this is from an education perspective, but I think too what we've all been commenting on is that there has to be that push and pull, that give and get of being connected, connected through care, so that bridge is a two-way street. There's that pushing outside your comfort zone and pushing, what can I do to challenge myself? And that, there's plenty of studies around that when you wake up in the morning, like looking for a challenge and saying like, all right, how am I going to seize the day? There's that positive, forward.
That way too.
Exactly. Yeah. As opposed to, if we are somebody that has, a really, debilitizing or something that makes us not able to participate as we fully can, then just kind of sinking into that and saying like, well, I can't do much, there's two very different attacks for life, and strategies for what to do with your time. So I think building these networks where we can, push out of our comfort zone, knowing there's going to be somebody to pull us along and to help fill in the blanks and help through whether it's giving information, whether it's just giving time, giving a hi or a handshake or a high five, having that human connection. That's something that's really important because that goes back into the system where we came from. We're able to, when we push ourselves through a challenge, we'll find different strengths that we can help others with. So I think, Christy, that's just, you gave a very specific example, but I think it when you are operating in harmony with either like a teaching partner or a coworker or a life partner or you're a caregiver, the person that you're giving care to, if there's that human connection and you really know each other, I think that's one of the most important things that we can do individually, because that will be infectious in a good way in the healthcare system. Touching back to what Tanya was talking about with joy, if we can enter into these situations with joy and with community and the intention to build, I think that's, we're going to be ahead of the game. We do actually already need to start winding down. I think we probably have a few grace minutes. I know we got started a little bit late, but just checking through some other input from our panel. As a polio survivor, somebody learned to go to every doctor's appointment with a list of questions they need to have answered. That is such good advice, because it's so easy to go through all the rigmarole of an appointment and you check all the boxes and then you're like, why are you here? I don't know. So have that written down ahead of time. I am responsible for the discussion and the knowledge and feelings I have when I leave, that agency and ownership. And then, Zoom has been a fine way for support groups to connect. I think we've seen a lot of very different and lasting changes in how we connect in groups through the internet with, the pandemic, which is very much, something a lot of us have experienced in many different ways. I think let's just get some last thoughts. So if you guys have anything else to add, just in your own experiences, what can be helpful to others or things you've noticed others do, turn in the corner to that, how do we take what we're doing individually to then change a system for good. And there was somebody was asking, could we just put together a roadmap? That could be a really good challenge. Like, what is the roadmap to make healthcare systems all over the world better for people with disabilities? So I'll do this in kind of a reverse order way. Tanya, I have you go first. So these are just kind of closing thoughts, and anything else that you would like to add for practical things you might suggest we can do.
Yeah, I try and always think about in a system, how do I make it easier for people to do the thing that is good for them, right? So thinking about digital literacy, how can we incorporate digital literacy into, especially for our elders, we have elders lunches here on tribal lands every day. And so is that something I can just incorporate into mealtime, thinking in that way as someone who works as a practitioner. But in terms of someone who, my niece is developmentally delayed, and I think about her experience, and some of the things that have been the most helpful to her, it comes from peers, right? And people kind of navigating this system just before her and helping her and inviting her, and our family, and teaching us along the way. And so really, I think grassrootsy is start with what you know and who you know, and how can you help each other and form kind of that local support network that you have, and then take it to try and reach to your neighbors, right? Who else is doing that work, and how can you connect? And we can connect over Zoom and social media and by phone and text and all these different ways. And then really thinking about, once you have these connections and you feel like you have support needed, and you're starting to have those conversations around, how can we fix this? How can we do better? Start calling your politicians and be an advocate in that way, because things don't happen at the local level that change systems. They happen at bigger levels. And so it really takes us reaching out and connecting. As someone who works in a clinic, I hate to have people come to me. I'd rather show up to them and bring it to them. And so as a patient, I think that way with our policy too. How can we bring it to them? Because they never ask us, right? They don't come to rural places, or they don't come and talk to the community that has the disability on how they can be better. We have to bring it to them. So that's kind of my thought.
That's great. Yeah, let's go right on to Taze, some closing thoughts and other anything else you have to share.
Sure. I mean, I think my biggest takeaway is, and just echoing what is being said more broadly, is just adding axes to the conversation. Adding perhaps lines of inquiries that might not be present in a space. I think a lot of disabilities, invisible disabilities, maybe there's some disabilities that might be visible, but with everything being on Zoom now and in virtual context, it might not present it the same way. A lot of disabilities get judged as character flaws, as kind of a personal affront, where especially from an HR standpoint, or from kind of the meat grinder of just interacting. A lot of disabilities might read as something like, oh, that person seems standoffish, or that person is unlikable or whatnot. And so, finding accommodations. I know Microsoft is one corporation that has a completely separate track, HR track, for hiring neurodivergent talent. So, policy solutions like that are just kind of aware that there can be a lot of misunderstanding, a lot of misreading. Nonprofits like Culture City are big on certifying sensory safe spaces, and the concept of building spaces that have sensory accommodations, and kind of exploring that whole frontier of what does that mean in architecture, what does that mean in venue design, what does that mean in product design, and then I think just building infrastructure for individuals who are disabled to find one another. The Disabled Voice Actors Database that I mentioned earlier is one way to do that. So, fantastic discussion. So, thank you so much.
Yeah, absolutely. Over to Elpita. Closing thoughts.
So, as we saw all through the process that, technology by itself would not be a solution, but, like how Tanya said earlier, that, if we have a case manager, which is following the case with them, it'll build like a sort of so much of empathy around with the patient. So I think technology itself is not a solution, but it's an enabler. But that human impact, human touch is very, very crucial. So I think that's my closing here. So I appreciate it.
Yeah, and we'll go David and then Christy, and then I've got a few final thoughts to close us off. And it looks like we will still be watching the video, which I think will actually be a great punctuation to this. So go ahead, David.
One thing I want to be absolutely clear on is to never underestimate an individual's ability to self-advocate, regardless of their diagnosis. Christy was talking about some of her contributions to the community, and I would add that with regards to technology, I may have a PhD, but I did not grow up speaking computer. Christy here has grown up speaking computer and is able to interact with phones and other forms of technology that sometimes leave me baffled. So that is a point I would make for any provider or anyone who would otherwise work with members of the developmentally disabled community and those with alternate means of interacting with the world. Christy, would you like to say anything before we close?
So for you,
Dan?
No,
Tanya?
Donna.
Okay.
Sorry. I'm bad with names. For the doctor appointment and nursing, what'd you do there?
So I'm the director of community supports, which is like the coolest job because I get to work with everyone in the community, and we think about ways that we can do case management, so work one-on-one with people, but also how can we do outreach and like public health initiatives. I know that probably doesn't clear it up, but we have a walking group, we have a little thrift store, we do all kinds of things. We host events and try to use the Native culture as part of healing. So that's been really fun too. Thank you, Chris.
Yeah.
You're welcome. Awesome. Well, I wish I could be a nurse, but I can't. And so I am a worker, so I'm glad I am working. And I'm glad I work with Tandem. And thank you. So I know Dan spoke, but teacher's taking over.
Okay.
on Monday, and I love that. And so, congratulations for your work.
That's Well, thank you, Chrissy. Thank you for being here. And that actually, you brought us back full circle, like when big things change. Because I know there's been a lot of change going on with your work and what you're doing. And I also love all the times that self-advocacy came up in this this panel. And I think that's the biggest thing that I would leave with before we watch this video, is that it's really important as we're developing any system to think through universal design and through co-production and participatory design. So, and that's the whole theme of this summit, I know, is nothing for us without us, is kind of that feeling of who, you find yourself at the table. The first thing to ask, and this is something all of us can do, is to ask yourself who's missing. But then the action you take is really what matters. And then that is saying, what am I going to do about it? How am I going to find those people? How am I going to engage? And I think we can all, in doing that, very simply, especially in the healthcare industry, become a community that solves problems rather than solutions in search of problems. So with that, I do want to give another special shout out. Looks like, no additional things in our Q&A. Shout out to the folks that participated in that different way in Q&A, like do things differently. That's the other thing I'll add. And so this video we're watching is a former student of myself and Tatum, and this was written in response to name calling on the internet, which is a very real thing that our youth deal with, and well, everybody deals with. So this is about a student taking back a word. He was called cringe on the internet, and he said, well, I'm not cringe. You, the bully, is cringe. And so Angela, if you want to go ahead, the panel, thank you so much for being here. And enjoy the rest of the summit.
I don't care if I'm cringe or not, but still not make fun of me like that. But I have a Down issue. Okay? You lost your mind. You know better. Don't on the bike say that stuff like that. You cringe. My feels is not cringe. You, the bully, is cringe. Boys are cringe one. Don't listen to the people say to you. Don't focus on people say to you in the comments.
I'm screaming out loud, trying to slow down. Where did all the time go? Can it be found? Like, hold on, can I get a minute? Like, hold on, I thought you were my friend, but I'm being hurt again. Now I just want this to end. Yeah, I just want this to end.
Yeah, boy, this is not nice. Don't make fun of the people who let you down. Cause I have found the hurt and all the pain in my heart made me sad. The pain inside my heart that made me feel bad. Cause I wanna be a baseball player. Cause I wanna be famous on TikTok. So don't listen to the bullies.
Screaming out loud, trying to slow down. Where did all the time go? Can it be found? Like, hold on, can I get a minute? Like, hold on, I thought you were my friend, but I'm being hurt again. Now I just want this to end. Yeah, I just want this to end.
Take my advice. Treat the people like you could treat them. Like, not be make fun of them. Don't make fun of people. Don't make fun of people.
Screaming out loud, trying to slow down. Where did all the time go? Can it be found? Like, hold on, can I get a minute? Like, hold on, I thought you were my friend, but I'm being hurt again. Now I just want this to end. Yeah, I just want this to end. What you see online isn't real, it's a highlight of their life. No, nothing ever changes, keeping it the same while you're scrolling through their pages. Your chest starts aching, heart feels vacant. So you sit alone while you're crying on the pavement, reading all the comments, seeing all the hatred replace me. Hard to get up when you're forced to fall down. Hard to hear silence when pain is so loud. But I feel my way out, no, I'll never fall down. Keep on pushing through pain, lift myself off the ground. Please don't listen to them let you down. The boys will let you down. Our strong nation.
Thank you, Dan, for sharing that video. I really enjoyed it. I remember watching it a few days ago, and then that song keeps ringing in my mind. So it will stay with me for quite a long time. It's been a very, very engaging last panel session. I found it very authentic and very interesting engagements as much as it was tech related. So as we bring day one of this summit to a close, we reflect on the powerful conversations, shared experiences, and collective commitment demonstrated throughout today's sessions. Personally, for me, these discussions, they've reinforced a simple but profound truth. Inclusive, patient-centered healthcare is possible when we listen, we collaborate, we innovate, and place dignity at the heart of every decision we make. Thank you so much to all our speakers, moderators, participants, and partners from around the world for making today such a meaningful success. To offer our closing reflections for today, it's my great privilege to introduce a true pioneer and champion of disability inclusion, Rotarian Kane Mason, who is the current co-president of this club. Of course, he'll be joined by Dr. Martha, whom I'd introduced earlier. Ken has dedicated his life to service, advocacy, and advancing the principles of diversity, equity, and inclusion within Rotary and beyond. Before relocating to Colombia, where he now resides, Ken was an active member and a leader in Rotary in the US, building a legacy of service that ultimately led to a bold vision of creating a Rotary club where disability advocacy would take center stage. 5 years ago, that vision became a reality with the founding of the Rotary Club of World Disability Advocacy, the first coast-based disability advocacy club in Rotary history. As a charter president and now co-president, Ken has helped transform the conversation from charity to justice, reminding us that accessibility, inclusion, and human dignity are fundamental rights for all. His leadership continues to inspire Rotarians around the world to remove barriers, celebrate abilities, and build communities where everyone belongs and feels included. Join me in warmly welcoming President Ken Mason and Dr. Martha, who will close today's historic summit. Thank you.
And thank you, Sam, for those kind words. And it's a pleasure for me to welcome here Dr. Martha, because as I've been doing this club for 5 years as a president and a co-president, and now Dr. Martha is going to take the torch along with John McFarlane, who will be the new co-president. So, and I'm interested, Dr. Martha, you're a medical doctor, and we had a lot of different conversations here today, a lot of interesting and very diverse conversations, I would say. And I was certainly looking at it as maybe a patient standpoint, but you as a doctor, how did you see today?
Well, I think that it was really, really interesting. I wish we could have more medical doctors here in this summit, but we need to take this these thoughts to the medical officers, they need to learn. They need to learn about what the patient thinks about to be inclusive, to be, healthcare that receives them with care, how many times we listen to some fellows that they couldn't have a mammography because she couldn't stand up, that's crazy. So this was absolutely an amazing day. I learned a lot. I feel motivated more and more each day. So it's going to be really challenging to fill your shoes.
Well, and looking at the event today, and we could spend a lot of time going through each one, but we don't have the time to do that. And I'm wondering about you. I mean, you're a retired doctor at this point. The medical, particularly for people with disabilities, is moving forward. I think that last discussion, I was thinking about, the technical part of it, having a doctor talk to you on your phone and do an analysis, that's nothing what you would meet people in person, but it does make a lot of good sense for somebody with disabilities to be able to be at their house and have a medical doctor to talk to right in a computer or on their phone or something like that. I can hardly wait to see how it's going to evolve even further, but it's a lot different from when you were a doctor.
Yeah, totally different, and now with the telephones, you can communicate with your doctors, and the health providers can communicate to request for some supplies and everything,
It's beautiful it's beautiful for a disability person, and then to think I was chatting offline here, but to think we were going from a spiritual conversation, which extremely was important, to a technical conversation. I mean, two extremes basically.
I love that.
Yeah, how diverse it was.
Different perspectives. I love that.
Yeah. No, it was. I mean, we could go on and on about everything that went on today. Your thoughts on all this? You're muted, Sam.
So my thoughts on all this is that our work is cut out for us as disability advocates. We have done something. A lot has been done in terms of policy. I think for us, as much as we want to focus on advocacy, we also have to push for implementation. The one thing that sticks with me was Sir Thomas Shakespeare saying that Rotarians, we have a strong voice. Let's use it to create that lasting impact, the change that we want to see. Just that voice, we don't need to do so much, and that will stick with me for a very long time.
And the three of us know, because we were all a part of the planning of all this, that the huge number of topics we could have covered, and you say, well, we only had 12 hours, and 12 hours seems like a lot of time, but it's a really small amount of time about the things we could have covered. And we know there's much more to be covered, and we're going to continue doing that under Dr. Martha's really direction. But other webinars we're going to be doing, maybe things like we talked about possibility of getting into chronic illnesses and how's that relate to disability. Chronic illnesses is not necessarily a disability, Dr. Martha, yeah, but it does cause disabilities. It does cause disabilities. And other things we talked about is post-polio syndrome, which is a big topic, and we need to do more on that. So we're going to do webinars on those kind of things. We didn't get into, or we won't get into this session about specific disabilities, for example, blindness or deafness, but we will do a session on that, I think, in the future. But let's just quickly talk as we wrap up here. Tomorrow, Dr. Martha, A lot of panels today, a couple of panels tomorrow. And more specifically, we have some individual speakers, and they're all doctors. Age-related disabilities, Dr. Mather, that's a doctor from Carlos from Spain is going to talk about that, right?
Yeah.
That is going to be a fascinating conversation. And I don't know if you're still there, Dr. Carlos, but we're looking forward to that. And then, basically when you're age-related disabilities, how to work with your doctor on that. It's a team effort. And then moving on to occupational therapy and physical therapy, we have a team that's going to discuss that. An occupational therapist and a physical therapist. Both of them happen to be from Brazil. Next, we get into the caregivers and the health advocates, which are an important part of this whole process. You want to, particularly for somebody with a disability. And we're going to look at that both from a professional caregiver standpoint to somebody who's a mother who is a caregiver for I think her son.
Yeah.
And then after that, we going to have a doctor from Brussels. And her topic is, Dr. Mather?
Yeah, it's going to be about prevention of congenital conditions, So she's going to put together all the congenital conditions that can be prevented,
Like-
It's going to be very, very interesting. And she will talk about health as a very important factor to prevent these conditions. So it's going to be interesting because it's a different perspective. Instead of treating the problem that it's already there, she talks about the prevention very, very early, even before the person gets pregnant. They have to be improving the health conditions of women.
And then we finish off with a doctor from he's from Mexico, but he worked for the WHO for many years, and so he has a very global perspective on things. And he's going to talk about. I'm going to pronounce it wrong as the medical name for it. You tell me, Dr. Mather.
Lymphatic filariasis.
Okay, good. And that you tell me is is the second leading cause of disabilities in the world.
Numbers have changed. Now. So, but it's a lot of people in Africa, India, Dominican Republic, Haiti, and it was eradicated from Brazil. That's going to be very interesting to know how they did it. Yeah, but it's very challenging because it's a disease that you can prevent, but when the person is already with the elephantiasis, which is the late stage, you cannot do anything. It's already a permanent disability, and it's a lot of work there for the governments and health institutions, because they cannot work, they cannot walk. You will see tomorrow. It's really interesting, a very interesting topic. Yeah.
So I look forward to that. I'll be talking with him about that. And thank you, Sam, for hosting this event. Thank you, Dr. Mather, for heading up our health section of our club. There's a lot of people behind the scenes that you don't see. A couple of them are still in this room with us. But they're the kind of the technical people, and it went as smooth as it went because of them. So I'm actually going to create a flyer and put it out to thank them publicly for the work that they have done, because If you left it up to me, it would have been a mess. So
Yeah, well, I also thank to the panelists, organizer, moderators, speakers, the technology team,
there you
and
go.
every person in the audience. They were so active with questions. You know, I was delighted just reading the questions. So it
There you go.
was great.
Yep, there's a lot of people to
It was
thank, and
flowing easily. I love that.
there you go.
Flowing easily.
There you go. And we'll be back again tomorrow. Please come back tomorrow, which is Saturday, June 27th. We did live stream this, and we will again. All the videos, all the discussions are on video, and we will be putting them up on the YouTube channel very soon. Very soon means like 6 weeks. It takes a while for 12 different presents to put it up on YouTube. And we are the Rotary Club of World Disability Advocacy. We're in 40 different countries, and we've been around for 5 years. We invite people to join us. Really, we invite people to join us. And if you'd like to, Rotary, this is our email, rotarywda@gmail.com. So write to us and say, hey, I want to be a member, and we'll be in touch with you.
And visit our website. We have a lot of information there.
What is our website, Dr. Mata? You know?
You got me. Let me. Can I share my screen because I have it here? Just 1 second.
Yeah,
okay, I'm going to tell you. Rotary Club WDA.org.
There you go. Okay. Thank you. We'll see you all tomorrow. Same time, same place.
Thank you.
Bye. Okay. Let me stop everything here. Stop
Recording.
Stop the live screen.